So, good morning, everybody. Welcome to our meeting in public. This is a public board meeting for our Integrated Care Board. We've got some apologies this morning for this public meeting, which include Mark Chamberlain, a non-executive director, Andrew Burnell, a member of our board who represents community. And we've got a couple of late arrivals. One is Stan Shreve, who will be arriving shortly, and one is Michelle Moran. Other than that, we're all here. I'm going to be chairing the meeting in a way that allows artificial intelligence to take the minutes of this meeting, which means I may need to address you by name, perhaps more than I would normally, and also means that it's important that we sum up at the end of each agenda item to make sure that we get a proper record of what we've discussed. And if for any reason I don't do that well enough, I'm very happy for anyone who owns the agenda item to help me improve that. I think there are some declarations of interest as we go through the agenda, but I don't think there's anything that's, that anyone needs to declare at this stage. That's correct, isn't it? We've been through apologies. So our first important job is to check the minutes of the last time that we met together. And those minutes are for a meeting that was held in public on the 10th of January. So I'm going to ask the board first, are there any matters in those minutes which you think are inaccurate? So first of all, we're checking the minutes for accuracy. Any comments about accuracy? And then secondly, I'm asking you about any matters arising in these minutes, things that we won't be discussing later on the agenda. So are there any matters arising in these minutes that anyone would like to raise? Okay, and now let's go to the back of those minutes where we have our matters arising action log. There are two things there. They both are flagged as completed. One is around the Care Quality Commission report on Tees Escombe Wear Valley. And that tells us that's complete and added to the board forward plan. And one is around performance update. And this tells us that the data issue around mental health has been resolved. Stephen, I don't know if we just want to mention the Tuve court case just here and now. It doesn't appear anywhere else. Or are you going to be speaking about that, Teresa?
Well, I haven't.
Well, I'm happy for Teresa to comment on it.
Do you want to just say a word on this week?
So the board will recall that there were three suicides within Tuve services that were subject to action by CQC, prosecution action. Tuve had pleaded guilty to deficits in care in relation to two of those, but sought to refute claims in a third case, and that's the one that went to court recently. I think I'm sure the board members will have seen for themselves that the statement that Tuve have released recognises that there were at times in the course of the pathway of care for that young lady that there were deficits in care, but not to the extent that the prosecution was alleged in terms of the deficits in care planning. So the Tuve obviously were not found guilty in respect of that final prosecution. I think from my perspective, I think it's an unfortunate position to actually be in when we are facing prosecution by CQC, and I would just like to remind the board of the actions in respect of the Quality Improvement Group work to make sure that we continually drive improvements. We did have the Chief Executive sharing the progress that Tuve had made as an organisation, and that's to be commended, but there's still an awful lot to be done.
Thank you. Thank you very much indeed, Teresa. Anything else in relation to those minutes and any other matters of any other business that anyone wants to raise? No. Okay. Well, that's moved us through the first part of our agenda neatly. We are going to welcome colleagues from the Yorkshire Ambulance Service who are going to present to us the Yorkshire Ambulance Service strategy, 24 to 29. I don't know where they are.
Just outside.
I think we're really pleased to welcome them. We know Jivan Gill, and I don't know the name of the gentleman who's with her. Anybody? No. Okay, let's wait for formal introductions. Hello, come on in. Jivan, well, you're presenting to the board, so I wonder if you shouldn't be at the front, really, with your slides. So, the board know Jivan Gill well from the ambulance service. We're always pleased to welcome you.
Thank you.
And Jivan, would you be kind enough to introduce your colleague?
Yes. Hi everybody, I'm Jivan Gill. I'm the Director of Partnerships and Operations for Yorkshire Ambulance Service for Humber in North Yorkshire. And this is my colleague Paul Mudd.
Hi, I'm Paul Mudd from Minoff and Head of Operations for all East Yorkshire and North Yorkshire.
Thank you both so much for making time to come.
You're very welcome. Shall I just...
Oh, you just need to be near a microphone. Can we just make sure you're near a microphone?
Shall we go this side?
Yeah, that's going to be better.
Yeah. I brought Paul along with me to answer any of the difficult questions that you might have. Oh, am I doing this right? Or
Yeah, you should be. Item 7.
Oh,
there we are.
fabulous. Okay, so thank you for inviting us. We've been invited to update on our trust strategy, which has been out for consultation for quite a while. We've did lots of consultation internally, but also with our partners as well. And thank you for those of you that made the effort to contribute either face-to-face or virtually as well. We've obviously taken all of that feedback on board and created our strategy. So we've changed lots within the document as well. It's not a really long document, so if colleagues haven't seen it, I'd advise, or I'd like to kindly ask you to have a look at that. I can send it separately, but it is on our website as well. We've changed within the document as well. We've been really clear about kind of our framework for success. So what is our purpose, which is to provide a coordinated, safe, effective and responsive patient care service, not only for the nines, but also recognising all of our 3 kind of service lines. I think when we did some consultation, particularly with our colleagues outside of YAS, I think that was not necessarily easily understood around what YAS does. Everybody knows around kind of the blue light services, but it wasn't really understood about the other functionalities that we've got as well, so we were quite clear to bring that out in our strategy. Our vision is obviously to be a great carer, great partner and a great having great people as well. We've changed our values slightly as well, so we used to have 6 values. It is still around kind of the key themes that you'd expect an NHS provider to have and a constitution to have. And that's around being kind of kind, respectful, teamwork and improvement. And that's not just internally, but that's with all colleagues and patients as well. We did lots of work with our values, particularly internally, about the 6 that we had previously and what do we want to go into as future and which ones that they resonated with more so as well. And YAS Together is about effectively how we're going to do that and how we're going to embed it. As well as the overall strategy, we were clear about we're going to have a number of kind of enablers plans in order to facilitate and delivery of that strategy. Clearly, clinical and quality being at the heart of that, along with people, partnership and sustainable services. So as a kind of an ambulance predominantly provider, we have lots of estate and we have lots of vehicles and so forth, and we need to make sure that that's sustainable into the future as well. So our 4 bold ambitions, which we'll go through briefly, is our patients, partners, people, pounds and planet. So this just goes through a little bit more of the detail of our values as well, which hopefully colleagues have been able to see as well and feel that they can resonate with that when you're having kind of any kind of dialogue with YAS staff as well. We're really keen. What we are also doing, and we have been doing this for a long time, is around recruitment. So our recruitment is all about values as well. So we do recruit on the values base as well as competencies of the individuals and applicants. Oh, sorry. So the first one The first one is around our patients, so we want to deliver a high quality service, making sure that we achieve kind of the targets and standards that we've been set that are most appropriate, and but we also deliver care closer to home as well, that we have to deliver as part of our category 1 responder, kind of a clear EPRR response, reducing health inequalities and making sure that we're an outstanding provider. And on the right hand side, that's how we're going to do that and what that means. So specifically around kind of our partners is making sure that we've got the most clinically appropriate response for patients, which is personalised. We're making sure that we're delivering care closer to home, and it's compassionate and evidence-based as well. This is just a bit of a diagram in regards to what YAS does, so I hope colleagues kind of feel more aligned to this and can recognise this as well. So that just shows, I suppose, effectively the in points around how you can make contact with YAS. Obviously, we would signpost where we can most effectively, and then we are looking at integrating where possible around particularly our clinical services around 1s and 9s, and then the effective kind of triage tool that we take place, and then where the patient could end up after that as well. And I think that's really easy to visualise, I suppose, our whole the whole 3 service lines that we offer as well. So our people, we obviously want to make sure that we've got high quality individuals as well that are thriving resource and research as well. We've got a good development leadership plan. Our paramedic profession is fairly young within the NHS. I think it's probably the youngest profession, and we're really clear that that needs to be kind of multi-professional, but also we've got a good clinical leadership and supervision model as well. We have got really good staff survey results this year, and we year on year increase that. Historically, the ambulance service is always slightly below the staff survey in regards to kind of complete statements, but that's because I suppose it's difficult as a dispersed workforce to encourage that. We encourage obviously freedom to speak up and reducing sickness and absentees and retention and recruitment, as well as making sure that we're an inclusive workforce as well. And what that will mean is that you've got an ambulance service that you're proud of, that we're a great place to work, we're open and diverse, and we've got a learning culture as well. So more importantly, I suppose, for yourselves is around our partners. So what do you expect from us? So we want to deliver that high quality service. We want to make sure that we're collaborative and we're collective, but we're also knowledgeable as well in regards to our subject matters. And we do that jointly together. So we work quite closely with yourselves, and we're an influence partner within the systems as well, both kind of locally, nationally and regionally. And we're contributing to a broader spectrum of just wider than just, I suppose, historically what we've done is the 9 service. We're really, really data rich in Yorkshire Ambulance Service, and what we want to do is make sure that we share that with yourselves so that we can kind of tackle some of the bigger health inequalities work, and we're not doing things in silo. Finally, our Planet and Pounds. So this is making sure that obviously where we can, we are reducing our impact on the environment and net zero emissions. We use our resources wisely, and we also use kind of clear evidence and data research in order to deliver the right quality of services. And how you would make sure that is making sure obviously part of that is being financially sustainable as well going forward. And that was it. Any questions?
Great, thank you very much indeed. Thanks very much for sharing that with us. Yorkshire Ambulance Service are one of our biggest partners, aren't they, in the work that we do. We work together on many things, and I know that to be successful, we all have to work together collectively. So you're a very welcome partner here, and we're grateful to you for sharing your new strategy. You will have seen all our eyes and ears pricked up because you've got new values. We're just about to have some new values too. So we're tuned into that. So thank you for sharing. I wonder if there are any questions for either Jivan or Paul in relation to the slides that you've seen and what we might expect to see differently in the ambulance service with this new strategy and new values. Louise.
Yeah, thanks, Stephen.
Hi, Louise.
It's good to see you.
Yeah.
I was just thinking about the health inequalities angle and the fact, I think we talked perhaps at the North Yorkshire Place Board about data and the use of data and the joining together with what already we know between us and how that might be really powerful.
Yeah.
And particularly when we're thinking about how we really support our communities. And I think that's a really simple strategy, and I get it and I understand that, and I think it's excellent. And I don't mean that disrespectfully saying simple. I mean strategies that you can understand, and this is what it's about. And the wiring diagram I thought looked really good, so I'm happy to talk to you outside of the meeting and think about how we work with our public health teams on an intelligence-led footing. So thank you.
Thank you. I think we were really keen to make it short and concise as well, so our staff as well recognise that document. So thank you for that.
Lovely, Louise. Thank you. Charlie and then Michelle.
Thank you. Just picking up on data, I had the pleasure of visiting you in action a few months ago, and I was extraordinarily impressed by the ways in which the service is data enabled in a very, very dynamic, real-time way. Such that I thought this was a kind of example for the NHS in the region. That's not directly associated to your values, but I think it's quite indirectly associated, because it makes your effectiveness all the better, because that data integration across the region is so good. So I just commend you for that.
Oh, thank you.
Michelle. Oh, and then Peter.
Thank you. Apologies for being late, but great end of the, I saw the presentation and what have you. And great about the data, because obviously we would support that in relationship to Interweave, etc. I know we've been working really closely with you for a long time. And apologies if you've mentioned this, again, for being a bit late in. I'm really interested around the AI work and the digital, and obviously how we're linking it in with 111, because obviously there's a lot of innovations in relationship to that triage bit. And obviously when we talk about 4-hour waits, that preventative piece, not getting people into the ambulance in the first place. So obviously if you mentioned it, but I just wanted to know what sort of, there's a couple of things on the horizon that I'd just be quite interested to know about, that's all.
Can you answer that? Do you know any of
So we want to do more here in Treat. So at the moment, we put our clinicians in either York or Wakefield EOC. This area, it's difficult to attract people to go and do that, so we've set up regional clinical hubs. So there's one in Hull and there's one in York now, so our clinicians rotate through that to do more here in Treat. We know there's a lot more, there's a bigger scope there for patients to not get an ambulance in the first place. At the moment it's about 8%-ish. We've got aspirations to grow that by putting clinicians in there and then having direct contact with clinicians in the field as well, so they can get peer-to-peer support. I think there's a lot more we can do on here in Treat. Our treat and refer rate, so that's where a clinician goes out, sees the patient, and decides that they don't need to go to necessarily to go to definitive care or ED. So there's more we can do with that. Having said that, York, North Yorkshire and Hull and East Yorkshire, we have the highest treat and refer rates in the rest of Yorkshire, and sit really well nationally as well. So it's about 52% of our patients end up going to ED-ish, but we know there's more we can do around that. And again, using the data that we've got suggests there's more we can do.
Okay, thank you. Thank you.
Do you know, you might have to just come a bit closer to your microphones and speak up, because it's quite hard to hear you.
Oh, sorry.
Jane.
Yeah, thank you for that. It's really interesting. One of the things that I think is a challenge for you is you cover a number of ICBs, don't you? You cross over a number of ICBs, and that must be really difficult in terms of finding the time to connect and engage with us all. Is there anything we could do that would make some of that easier for you?
I was going to say I don't think so, but that's not in a negative way, because I think the organisations recognise that, and hence why they've got, I suppose, myself here. So my role has changed fundamentally as well. So now we've got kind of the operational elements in it. So Paul and I work quite closely together. So I think Yaz recognised that and has, I suppose, adapted to the ICB. So there is my equivalent both in West and South Yorkshire as well. So I think it's just linking in with the right people.
Okay.
Yeah.
Thank you. Peter, sorry. Oh, gosh.
Morning, and nice to see you in person, because I think we've only met on screen.
Yes.
I echo some of Charlie's comments, having visited your headquarters and seen things in action. The ICS has also, this ICS has also gone through a simplification of strategy, and as a result, children and young people have come to the top line, and we're talking about a generational change for children and young people. So maybe something to take away as a challenge, if you like, is how will this strategy provide some opportunities for thinking about children and young people in a way that maybe hasn't been thought of before. And I'm just thinking about how people are transported. Quite interested in your anchor institutions, your apprenticeships, thinking about where your volunteers are working, because obviously as a brand, it's a fabulous brand for children and young people, and I think you've just got a real role there to play.
Yeah. Can I ask you to deal the kind of the community stuff in regards to, because Paul does lots of work with educational kind of facilities, and then I can pick up some of the other bits if that's all right.
Yeah, so part of our community engagement strategy is to deal with sixth form colleges and getting into people in areas, particularly areas in Hull and East Yorkshire where they haven't considered Yorkshire Ambulance Service as an employer. So getting in early around what it is we'll be looking for, what they need to do is continue their education so that they're a suitable candidate when it comes round to leaving college or going to university. We deal with York St John's University and Hull University and do a lot of work with those. Some of our staff rotate through those doing lecturing. And we recruit heavily from both St John's, well, from this year St John's, but Hull's been a really, the whole degree programme has been a really boost for us in this area because it's difficult to attract people to work in Hull and East Yorkshire. You have Olivia or you don't. It's not so much difficult in Sheffield and Leeds. So we work with people, and we're getting younger and younger. So getting into colleges, getting into schools, talking about the appropriateness of usage for a Yorkshire Ambulance Service, but also career opportunities.
And that's broader than just the 9, so it's not just a paramedic or not. Obviously, clearly there's lots of other roles, so we're trying to kind of facilitate some of those as well for those. In regards to the service itself, I think I'll go back to our health inequalities in our data. We need to utilise that around who actually uses the service, what they use the service for, and how we can change it. And we're really keen to work quite closely with our places as well in order to facilitate and do stuff jointly around that.
Thank you. Nigel and then Stuart.
I was going to pick up again on the data bit because I know your colleague Ola comes to the shared care record delivery group that spans all of the ICSs in Yorkshire, and picking up with Michelle's point about Interweave. Interweave is the engine behind the shared care record, and we're getting very, very good data coming through shared care record from that, so that's brilliant. I suppose my thing about hear and treat and see and treat is to make sure that we don't give you the job card of the problem of access into other parts of the system. So the pharmacy first, GP, primary care access has to be boosted as well as the things that you do, or else actually you're going to be given the things that really you shouldn't be given. And then that has a knock-on for all parts of the system. So I think we just need to be open and honest that, you know, it's an access issue, and the most appropriate things need to come through the ambulance service, and where it should be dealt elsewhere, it should be dealt elsewhere.
Yeah, agreed. Thank you.
Thanks, Nigel. And Stuart.
Yeah, thank you. Hi. Climate change. Where are the big sources of carbon, and what are you doing about them?
Well,
So
vehicles being
vehicles and our estate, pretty much. So we are very mindful when it comes to. So we've designed our first carbon neutral estate would probably be in Scarborough. It's been put on hold because of capital, pretty much. But that would be our first estate that'd be carbon neutral.
So forgive me, that's on the drawing board at the moment, is it? Rather?
Yeah, the plans. Yeah, it's all done. We've purchased the land at Scarborough, which is right next to the hospital. Unfortunately, the capital's not quite there to start that build, but that once it's done, that will be the first carbon neutral estate in years. Vehicles is a real challenge for us because
we're piloting some in PTS, aren't we?
Yeah, electric vehicles in PTS, but it's really difficult for our A&E vehicles because of the amount of electrical equipment that they need. So they pretty much need charging all the time because of the electric equipment that's on there, defibs, etc., etc. So it's a lot more difficult. I know they've talked about hydrogen vehicles. That's pretty much something that we've had in the past, but we're not quite there yet. But yeah, PTS will be the first to go. Patient Transport Service the first to go with fully electric vehicles. But then there's the issues of obviously making sure our estate's capable of charging those, having chargers everywhere, etc., etc. Our responder cars are pretty much fully electric, though, or partially electric. So are our commander cars. So like my car is partially electric.
Right, thank you.
Thank you.
Stephen, and then finally Anya, and then we're done on this one.
Thanks, Chair, and thanks for a really clear and high-quality presentation. We're in a public meeting, and I suppose and it's very impressive what you're doing, things you were talking about in response to the questions. But I guess what the public, and I suspect our board, would want to be assured about is how does this strategy mean an even safer and more responsive ambulance service, particularly in relation to the emergency pathway? Now, captured in your title, that's not just the ambulance services business, because that's part of being a great partner and other partners have got responsibilities. But I think it's really important that this strategy, if you could just say a bit about how you think this strategy gets us into that really sustainable position of a high-performing, accessible, responsive in this case, safe and high-quality service.
So we clearly need to do more with our response times. Our response times aren't there where they're needed at the moment. Some of that's down to staffing levels, so we've been really proactive with recruitment, especially in North Yorkshire and Hull and East Yorkshire. Like I said earlier, they're not easy places to recruit to. The coastal area, I know full NHS has issues recruiting to the coastal areas. We've had issues. We've done some international recruitment over the last couple of years, and that's been really successful. There was some more landed this Saturday, actually, starting in Hull week on Monday. So we've been really proactive with our recruitment, because we know that despite the challenges that we have at the hospital, even if we went back to pre-COVID issues, we still need to recruit more staff and retain more staff. So some of the strategy about getting the right people and keeping the right people, it's a big issue for us. There's a big pull on paramedics pretty much worldwide. You know, paramedics could go pretty much work anywhere in the world, but certainly could. We all know what attract paramedics to other parts of the NHS. So it's incumbent on us to make YAS a good offer, a good place to work. So yeah, we do need to improve our response times across YAS, but particularly across Hull and York, key areas for us with regard to that. Some of the challenges it talks about around making us a sustainable organisation, an environmentally friendly organisation. Again, we're very heavily reliant on diesel for our vehicles, which again isn't environmentally friendly. So the challenges there around making us more sustainable. And pick up something.
Yeah, I think finally it's probably, I suppose, one of the reasons why we're really keen and thankful to be presented here is working with yourselves around the room, because they're our patients, aren't they? They're not just they're ours together, and what can we do jointly together, not only just to kind of benefit one, but it's that whole patient journey, that whole patient pathway, and if we can do some of the preventative work early on, in theory they shouldn't come through this. So I think it's working jointly together would be the final bit.
Thank you. Anya.
Thank you, Chair, and thank you for that really helpful presentation, as other colleagues have said. It's a comment and almost a bit of a plea for us all, really, and it's linked to the point that you've just said about recruitment and retention, and linked to the points that other people have made, and that's around, I guess my plea is, can we, as a system, just stop this archaic view of looking at qualifications as an entry route? And it was prompted actually because I'd seen you were advertising for, I think I'm going to get the title wrong, but it was ambulance technician, I think. And again, it was still the idea of you need GCSE A to C. We know that many people in our region have got fantastic skills. They would probably be brilliant at that role. But unfortunately, that requirement of an A to C GCSE is a limiting factor, not because they don't have the ability, just because they haven't had that educational opportunity to achieve in the way that they could. And you touched on the degree programme at the University of Hull. I used to work there, and the degree programme was launched. And again, the number of people we had from this area that came via the certificate route, where they didn't have any qualifications, and they'd always felt that that was a completely limiting factor, and they went on to complete the degree programme and are probably, you know, some of the finest paramedics you've got. And it's just a plea to all of us, really. Can we look at that, please? Yeah. Because it is such a limiting factor for many parts of our population. There must be other ways that we can demonstrate those competencies without them having to come in with a set of GCSE. So sorry, it's aimed sort of at you, but it's something for all of us.
That's something that we're aiming to go away from within YAS. So like Jeevan alluded to, our recruitment is around values. Do your values as an individual match our values, that match the NHS values, as opposed to what pieces of paper have you got qualifications.
Yeah.
Thank you. Thank you both again very much indeed for coming. You can see that we're quite interested in Yorkshire Ambulance Service. We do recognise you as being absolutely part of our close partnership family. So you've been very welcome. Your presentation was welcome. Thank you very much indeed.
Thank you for your time.
Have a safe journey wherever you're going next.
Thank you.
Thank you.
Very good, thank you.
Bye-bye. Great. Let's move on now to item 8. Item 8 is around the board assurance framework. We always look at the BAF, the Board Assurance Framework, at the start of our board meetings. And we do that because we want to remind ourselves, are those risks that we've identified as being the greatest risks to our strategic ambitions? Have we collected the right ones in the right place, and do we have the right mitigations together? So this is a way of enabling the board to have constant oversight of the risks we face and to be assured by the mitigations taking place as we go along. We try and make sure it's a really dynamic document, so we do change it and we do update it. And I think Karina will probably talk us through the updates to the BAF this month.
Yeah, thank you, Chair. Just to talk through some of the updates, they're mainly in the strategic objective of managing today, where the updates have taken place. The first one, interestingly, based on the conversation we've just had, patient safety and positive health outcomes. There was mitigating action in there around managing the clinical risk with ambulance handover delays. Obviously, there is the target date has been adjusted, but there is also an update in there that we looked at the clinical risk framework and decision tool that was developed during December to support collective sharing of risk across the whole of the system at times of escalation. So there is a little bit of an update there just to describe that. The risk reference A2, which was the 2022-23 financial performance, I think that's just bringing that to a full close now, and noting for the board that risk has been completely closed. And obviously there's an update to the 2023-24 financial performance. Based on our current position and what we know, the risk score has been lowered. There's some additional positive assurances and key controls that have been put in place that support the reason for that reduction in the impact in the likelihood, which has reduced to a number 2. The next one where there's been a little bit of an update is in relation to risk reference A5, which is the states. Again, we've looked at the risk score and lowered that. It's the likelihood of that risk materialising that has changed, and it's fallen out of appetite now as well. And there's some new positive assurances highlighted there, including the ICB infrastructure plan work, which has commenced. And then some additional gaps and controls where further mitigating actions are taking place. And then I think the final one is just in relation to performance standards, risk reference A6. And there's some mitigating actions where there have been updates provided in relation to the targets that were set for some of the mitigating actions. So one around urgent emergency care faster plan, prioritising immediate actions, and the cancer recovery plan, I think both of which will be talked about in the performance element of our agenda.
Lovely, thank you very much indeed, Karina. Stuart?
I wonder if under the strategic objectives collectively called Managing Tomorrow, we should have something about the financial risks that we face over a medium term. If we are the system that needs to be in balance financially, and we have all manner of challenges in that regard, some of which won't be solved within a single budget cycle, we should have I think a medium-term financial risk, which implies all sorts of other things, transformation of the way we deliver services and so forth.
Yeah.
But that's maybe the risk to home in on.
Does anyone have a contribute to that? Jane, do you want to comment?
Yeah, I think we probably should. That's a good reflection. I think, Stuart, we do want to do that.
Can we do that for next month then, please?
And we've included the medium term as a mitigation for the current risk.
but I think it needs probably pulling out separately.
Yeah.
But that is one of the mitigations that exists. Yeah.
There's sort of two risks. So there's some very immediate things that we need to do for a financial year about to start, but then there's more systematic stuff we'd have to do for longer term.
This gives us another vehicle for tracking that, doesn't it? Thank you. Bushra.
I just wondered if we were perhaps missing in managing today some of the risks around primary care. There's been an awful lot going on in primary care just lately. There's a lot of unhappiness about the imposition of the 24-25 contract. There's a lot of talk about industrial action that could be taken within the contract in primary care and how that could really impact on the system. You know, things like not engaging with advice and guidance, not engaging with any of the digital things that are non-contractual that primary care currently does to help the system to flow and to work. If all of that was taken away, actually, what would the impact be for us as a greater system? And I'm also aware of some concerns about practices that are currently running in debt, where partners are not able to take drawings. And what would the impact be if a large practice were to become bankrupt and have to close and hand back its contract? What would we be doing about that? Do we have a plan or a mitigation in place? And that's not really anywhere that I can see on here.
Thank you. Stephen?
So I think that's entirely valid, and I think we could probably reflect that in just trying to crystallise that in an action from what you said. I think what you raised, though, is a really, underneath that, something for future reference, which is, as managing today and tomorrow, is the primary care strategy for this ICS, because I know it doesn't feel like on the way, but I think it's if I just flag that, not for any more detailed discussion, but I think it is increasingly a high priority to be really clear about what that looks like. And I mean, I just draw out what you said about the debt position, but more generally, there's all sorts of issues about premises, there's all sorts of things. You know, how do you move towards a critical mass of primary care colleagues working together at place? I mean, there's a whole set of issues there. So I know there's work going on around that, but I think that's an extrapolation. I'm not just talking about the BAF here. I'm talking about something that we will need to be considering as we go into this new year. But certainly.
Amanda?
Yeah, so I think it's really well made point. I think that a lot of that's picked up on the risk register, not necessarily on the board assurance framework. So I can't remember in my head exactly what's in, but I'll go and have a look and make sure it's reflected on there, because I think it's a risk register issue that we need to make sure.
The BAF issue might be primary care strategy.
Yeah, I think it's a more strategic risk around primary care that BAF would consider.
I wondered if you want to make any comment, Nigel.
No, I would agree with it. I think you know, Simon and the Primary Care Club, we've got a strong advocate for looking at this in the round with the wider primary care contractor groups, and to really push on over this next year to get to the outcomes that you want. I think the individual contractor model is difficult. It's a difficult one to square. So some practices will be unsustainable because of the business models that they run. That's me being open and honest. And we have to probably think of ways that we can open up those discussions and think about sharing good practice. What's the other models of primary care business that we can start to engineer and help people to get to. But absolutely, we want a thriving and sustainable primary care contractor group, because if we don't, then we won't have the foundations to build the other bits on.
Okay. So this is something that we'll take away and have a look at, sounds like, doesn't it? And get back to you for next month on where what we think the risk looks like in relation for the back. but a nice point, Bushra. Thank you very much indeed. Any other comments in relation to the board assurance framework? Okay, let's move on. This is item 9, Anya. As you know, we seek to hear from those people who use our services as frequently as we can, and in a way that tell us the way that the board thinks about the decisions it makes and the discussions that it has. It's an ongoing process. We're getting better and better at doing that. So I'm very pleased to ask Anya to speak to this paper around engagement and insight, which is providing us with a snapshot of what we hear about the way people are experiencing the services our NHS provides in Humber and North Yorkshire. Anya.
Thank you, Chair. And building on that, as a reminder, this is a snapshot of activity and insight gained over the last couple of months through teams within the ICB and through our colleagues at Health Watch. Just to build again on the Chair's point, we do want to develop this further and are looking at ways to bring more meaningful representation of patient and public voice into the board meetings. So if anybody has got any particular thoughts on that, they are very welcome, and we look forward to sharing some of our thinking on that for the future as well. So firstly, just in terms of the key themes, and again a caveat, if you like, here, that these are the key themes that we are hearing from patients and members of the public. They're not necessarily fully evidenced, but this is either the perception or some people's reality of the experience that they're having. So some of the themes over the last couple of weeks relate to the ongoing issues around cost of living, and particularly relating to transport, where the cost of public transport, increased fuel prices and taxes means that some people in our community either can't attend medical appointments or are prioritising other aspects of their life, and so they're actually refusing treatment in some cases, not turning up for appointments because of that cost of living impact. Mental health remains an ongoing issue, particularly as we've discussed before. Access to CAMS and particularly autism and ADHD services. There have been some comments received particularly through Health Watch around issues relating to long waiting times for crisis line and for talking therapies. And finally, and it won't come as a surprise because it's a usual issue for our members of our community, are issues around access to GP services. Over the last couple of months we have received I guess a little bit more to suggest that some online systems and digital access platforms are not necessarily working as effectively as they could in some cases. I would reiterate that in the main, when people can get an appointment, they are happy with the care and service they received, but again there's a sense in some parts of our community about long waiting times, and as I've said before, unfortunately this does build on perceptions. We hear quite a lot, oh, you can't get a doctor's appointment, so I'm not even trying, when the reality may be different. I'm just going to whip through, if we can move on, just some of the key pieces of engagement that have taken place.
Can I just stop you before you do? Just to say, this issue of patient transport always occurs, doesn't it? It always recurs. The NHS is not a transport provider, that's for sure. We know that, nor are local authorities in their own way. But it isn't an issue that we can hide from. So I just want to log that really in our board discussions, that as we go on to develop services, we do have to think about patient transport and how we might work better with the third sector and with other organisations to make sure that people aren't excluded from health because they find it difficult to travel. Jason first, then Stephen.
So just picking up on that, so I think I referenced a couple of meetings ago that we were looking to organise a roundtable led by the VCSE Collaborative around patient transport, and we did that about 6 weeks ago. As you can imagine, really well attended, and actually a real kind of lively discussion. And I think the conversation, I think there's a real mess around understanding what community transport exists, actually how we might use it differently, because there's the issue about medical appointments, but also some of the preventative stuff, particularly in rural areas, about being able to attend a support group which is 15 villages away and the bus goes once a day. So where we've kind of left it is we are commissioning through the VCSE Collaborative a piece of work to understand what patient transport looks like and actually what we have as our assets, to then have the conversation that says what more could we do with that. Because what people are saying is they'll be really happy to pay a cost, but actually it needs to be at a convenient time, and actually it needs to be accessible, and it doesn't need to be, one of those ones where you're waiting 15 minutes and it doesn't turn up and you need to make alternative arrangements. And in particular, there were some real concerns around having to travel, even in urban areas, long distances to be early for an appointment that meant getting up at 5 in the morning just in case the bus didn't come. So I think we are starting to do that. I think we've started the VCSE Collaborative, but we kind of recognise that there is a system conversation around transport that we need to have based on what we come back with. But I have to say it was an incredibly well-attended webinar through providers, members of the public, and I think it probably gives us a direction of travel that probably supports what's being said in that piece of insight.
Thank you. Thanks, Jason. I'm interested to hear about that. Stephen?
Two, three things. So I think that's really helpful, and that's absolutely right. I think whilst it's entirely appropriate to talk about this in this forum, the place where I think we need to develop this is in the Integrated Care Partnership, just to make that point. But more specifically, when we need to think transformation also in this context. So yes, of course, physical transport may be necessary, but how much are we employing technology and other things to prevent people getting up at 5 o'clock in the morning? And how much more services are we going to provide closer to communities in people's homes? I think that's really an important point. The other point I want to make is it is inevitable, if we follow the absolute mainstream priority of government, to address the backlog in the waiting lists and to drive elective or planned activity and routine activity really hard, that we may have to think about different locations and concentration of some of those services to meet that objective. So I think when we talk about transport, we have to talk about those things as well. But ICP, I think, is a place to develop what Jason's talking about with that useful baseline. Thank you.
Anya, returning to you.
Thank you. If we could move the slide on, please. I'll just whip through these because hopefully you've read them. This is just an update on the patient engagement network that I spoke about last time. We have increased involvement in that network, which is really positive, and thanks to the chair for taking part in the last session, which I think was really successful. So this is a key means of engaging with those that are already somewhat engaged, but being able to furnish them with more informed information. If we move on, please, we did an event at the university in Hull and engaged with 30 students. I won't go through this in detail, you can see it there in the pack, but what we found was that actually the experiences in relation to the NHS from our student community were not dissimilar to those experiences that we find in the rest of the community. And if we can move on again, what was, I suppose, interesting, some of us may find it interesting, is that half the respondents did say that they access medical care primarily through their GP, albeit nearly a quarter said that they use NHS 111, which was interesting for that demographic, and particularly some students where English isn't their first language felt that the translation aspect of 111 was really helpful, which is something for us again to work with. And just a few nuggets in there as well. Again, perhaps unsurprising, but helpful to be evidence that particularly the student community really value small, sharp bursts of information rather than long monologues. Instagram and Facebook being their preferred points of reference, and most would Google if they wanted medical information rather than going direct to a medical professional. And there was a sense that it would be really helpful, and perhaps something to pick up with Charlie as well, if we could have more of a relationship with the universities for them to disseminate health and care information through their internal channels. So some helpful insight there that we'll be able to work with. If we can move on, please. We held a really, really fantastic event recently with the Health Gospel in North East Lincolnshire. This is a community group supporting people who have come to live in North East Lincolnshire from Nigeria, Zimbabwe and Uganda, and we met with over 50 people from that community, some of whom are living and working in the wider community, some of whom are actually working within the NHS and health and care sector. So it's a really, really great opportunity to engage, and we will be having further events with them. One of the key reasons for getting that group together was to understand how they access health and care information. If colleagues remember, we talked about a situation that had occurred in North East Lincolnshire at the back end of last year, where a member of that community had not known how to access urgent and emergency care. So we did a lot of work around how they actually access information. Was the information on our website helpful? Was 111 information helpful? So we've got some really rich insight there. In particular, some key topics that came out were around understanding vaccination schedules, particularly with families coming with school-age children, and understanding how they can get into the vaccination programme, and around emergency dental care. Just, if we can move on, please, just a very quick update, because we brought it last time in terms of the engagement work that had been undertaken to support the move of the walk-in centre from Storey Street in Hull to the new UTC at Hull Royal Infirmary. Just to give a very quick update, I know Andrew's not here today, but there were no particularly negative or issues that stopped that move that came through from the engagement. That went ahead, and the new site opened its doors in early February. The initial feedback is really, really positive. All the services are not fully operational yet, but it is regularly seeing over 120 patients a day, which is an improvement on what was at Storey Street. And at the time of writing this, approximately a quarter of the daily activity is being streamed from the ED at Hull Royal Infirmary, which was absolutely the intention there, and that is likely to continue as more services come online there. But very, very positive patient feedback as well. So I think whilst engagement is only a part of that, I think it's an important part of the wider success story, or early success story, around that facility. Moving on, I won't go in detail because you can read it yourself, but again, some of the key issues coming through from our Health Watch teams in the area, similar to what we have presented last time. And again, if we can move on, this is from just a snapshot from our ICB experience team and the communications team, who deal with queries from our MP community. So you can see there again, not surprising and understandable, the main theme and topic there continues to be dental access and the lack of NHS capacity. But there's been some really helpful engagement, particularly with some MP colleagues in our patch around that. So that's all I want to say, Chair. If anybody's got any questions, we're happy to take them.
Thank you very much indeed, Anya. A really nice spread there of different communications. Any questions for Anya? Yes, Bushra.
So the walk-in centre, moving to Hull, obviously A&E are managing to move some patients in there. Are we actually seeing any improvement in A&E's performance as a result of that?
Yes, we are. It's about 10% improvement.
Brilliant.
Charlie.
Thank you very much, Anya. Great to hear about the Hull University session. Would love to see something like that in York, but also to clearly differentiate it between those who live on campus, where there is a large GP practice which provides very nearby support, and those who live in the city who are properly registered with a range of GPs around the city. Be quite interesting to understand the differences of experience of those two groups, and that's probably the same in Hull. York St John's also got a site on campus, but its students are spread around the city. I'm not sure which one would be better, actually, the on-campus or the distributed provision, but it would be really nice to know.
Yeah. Happy to pick up on that, Charlie. Thank you.
Any further? Oh yes, Amanda. Sorry.
Yeah, thank you. So I was just interested in the young people's observation around difficult getting through to practices on the phone, because I want to think about how we can encourage them to go through the NHS app. So we know that as part of the investment programme over the next 3 years, there's going to be a significant investment in technology and digital. And really, the NHS app should be sort of the front door, particularly for routine care. And also, if we can think about how we expand it around the pharmacy first. A lot of practices now have consultations available to book on the app, and also the ability to have a conversation, a clinical conversation, not immediately, but over the course of sort of 24, 48 hours. And the young people of today are going to be continuing to use services and want to use it in that way. So the more that we can do around that, I think will be helpful, really. So as we roll that out more, it might be useful to get a bit of a working group if you've got a cohort that we can engage with.
Absolutely, very quickly, 100% agree. And as we've discussed before, I think getting some of that user experience insight as well, because I think we've touched on it, that at the moment, whilst there's huge opportunity with the app, it can also be a little bit tricky because some practices switch on elements of functionality that others don't. So to give a consistent message and to have a consistent user experience can be quite difficult, which then can lead to lack of confidence in use, etc. But absolutely, I think if we and there is some work that we're aware of within the ICB already, but how we expand that work will be really, really helpful.
I think in terms of repeat prescriptions particularly, that takes the workload away from the phone lines, and that's worked really well, and we've done well in helping support patients to use that for repeat prescriptions. So you can
100%.
Thank you.
Jason.
Just really quickly on the app thing. So we did quite a large piece of work probably about 18 months ago now through VCS organisations, community organisations around registration on the app, particularly communities who wouldn't use it. And that worked really well. But the learning from it was that people found it easy to download the app, but actually trying to use the app and understanding all the things that were on there was the challenge. So actually, we got to the point where we had to demonstrate to people how to access the medical record repeat prescriptions. Once they got it, they were really kind of comfortable with it and probably would never phone again. One of the issues that's really come up has been around letters from acute that are on a different system but actually are going via the app. So actually, for example, Whole Patient Knows Best. It's a really efficient system if you know that the letters are coming on the app and you can download the apps, but people are still waiting for letters coming through the door. I suspect there may be missed appointments because people are expecting the letter that says you're there. So actually there's something around actually how we almost take it from the level of beyond the NHS app bit to what else actually is going to be on there, because I think that's really significant, and I think people are still thinking systems are going to be the same. So I think this probably we can pick up. We've started a piece of work. We've got some really good connections, particularly with groups who ordinarily wouldn't use the app, particularly BME communities who probably don't have some of the technology. I think we could just lift and shift what we've done already, but make it a little bit more sophisticated, because most people, remember, got the app because they wanted the COVID pass. That was why they got the app. And actually taking the time to say prescriptions, appointments, medical record, actually once you get your hand on the system, you'll probably never ever pick up the phone again.
Huge opportunity.
Stephen, finally.
So again, just channeling patients, listening to it's really good. I think this is a good step forward in getting this information. But we sort of, as I suppose, we say, well, so what then? And I know you alluded to this at the beginning. So I might be saying, well, what then? On the back of those themes and things we said, as a system, are we then taking forward, and how? So I just wanted to land that point in the context of it's useful, it's helpful, and it's an interesting discussion, but what?
Okay, thank you. These three agenda items that we've just been through, item 12, hearing from Yorkshire Ambulance Service, item 8 around our board assurance framework, and this item 9 around the voice of lived experience are kind of the prelude to our board. They set the tone for the board meeting ahead. So I'm now going to move us on to agenda item number 10, where we start to get into the absolute business of the board. And this always begins with an update from the Chief Executive. So Stephen, to you.
Thank you, Chair. 4 items. Martha's rule, I want to just flag, and Therese, it'd be helpful just to understand how we're going to assure ourselves as an ICB about what's required here. I want to talk about the budget last week, and Max, if I could flag, it would be really helpful to get any insights or thoughts you've got around the sort of digital dimension that came out of that. I just want to highlight the letter that we've written to the Prime Minister about a smoke-free generation and that whole process going through Parliament. And then there's just 3 things on that are really good things that are happening in our system I want to flag. So those are the things. So on Martha's rule, I think probably most people are aware of this. This is a case of Martha Mills, I think her name was, Northwest London, died unnecessarily, I think, from sepsis because of lack of communication, really, and a lack of alignment between different professionals working in this field. So there are 3 things associated with Martha's rule. The first one, that all staff in NHS trusts must have 24/7 access to a rapid review from a critical care outreach team. All patients and their families, this is really important, element, I think. That's all important, but just to emphasise it. Carers and advocates must also have access to the same 24/7 rapid review from a critical care outreach team. And thirdly, which is the point really around assurance, Teresa, if I'm the NHS must implement a structured approach to obtain information that's related to a patient's condition directly from the patient and their family daily. And that's all intended, of course, to avoid such an incident again. So I just wanted to flag, it's very important, I think.
Yeah.
And it was highlighted a couple of weeks back also by Amanda Pritchard. So, Teresa, would be just helpful if you could. You might have been doing it later, but...
No. So I think there's a number of things to say. There are certainly challenges with this, but fundamentally this is about culture and listening and properly engaging with families, patients and carers. And actually those direct conversations about, do they understand, are they happy, have they got any concerns? So I think that's the ethos, and actually to give an opportunity to seek advice and support if they are not 100% happy. I'm going to come back to the 24-hour access bit around the critical care outreach, because I think that's not necessarily in place across all services. I'm talking across England now, and may be a challenge in some. But in terms of the initial implementation, there have been some pilots conducted in organisations across England, and that particular sort of help, where to go for help to get access to more information. Those pilots have actually been really successful, but staff have used them as much as families have used them. So there is definitely some learning from those that we can take into practice across the ICB. It's obviously being taken forward through the nursing group across not just Humber and North Yorkshire, but actually across North Eastern Yorkshire, in terms of the learning from implementation and the pilots. And each organisation is preparing their own plans for that. What we will have to agree is how we actually, as an ICB, as part of our quality assurance arrangements, actually agree what that assurance at an ICB level looks like. So just come back to what I think is going to be the key challenge, and that's the specification that it's 24-hour access to critical care outreach. That's something that we've got to look at as we go forward with this work. The pilots have actually identified that in some cases, actually, it's not critical care outreach that's required. It's just actually the opportunity to have another conversation. But we'll obviously build that into the implementation plans.
Thank you.
And the point about assurance, I assume we'll seek assurance on all of that throughout.
Yeah, that's what I say. We've got to work that through in terms of what that assurance looks like for an ICB. Yeah.
Okay, I'll move on to the budget, if I may. So the government announced in the budget last week an additional 2.5 billion of day-to-day revenue for the NHS in England this year, or this forthcoming year, financial year, April to March 25. What that means in practice is we'll just maintain where we are. So the sort of technical term, it's a flat allocation. What therefore means is that the financial pressure on the NHS everywhere and here in Humber and North Yorkshire remains really challenging. I channels the point that you were making earlier, Stuart, when we were talking about the bath. So just to be really clear about that, there is a big piece of work going on nationally, which has been briefed to all chairs and chief execs on productivity, and all I will say about that in this meeting is we're doing a piece of work within the executive and the wider leadership team across our system to sort of understand what that might mean for us and how we're going to take that agenda forward. The important thing to I suppose, get across there is I think we've got lots of information about productivity in the acute sector, not so much around patient pathways, mental health, primary care, etc. So in the context of system working, collaborative working, generating really positive outcomes for patients and communities from integration, that's where our thinking needs to go on productivity, because sometimes driving productivity in one sector has consequences that we wouldn't necessarily want. So I just want to make that point. We'll be coming back with some of that subsequently. And then, as I sort of flagged, there is a significant sum, although, I mean, as ever, there's probably some nuance around the numbers, but there is new money to invest in digital technology. Now, that's all aimed at trying to bring the NHS into the 21st century, what you'd expect to see from a bank in our daily lives, for example, happening in, and some of those examples earlier that we were hearing, like somebody getting up at 5 o'clock in the morning. And so this is what this all is all aimed to do, to move, make a significant transformational step in how the NHS operates, which I'm sure we could all, and the NHS app we were talking about, I'm sure we could all get behind that. But Max, I just wondered whether you got any observations about that for the board. Thank you.
Yeah, very happy to. Thank you, Stephen. So it's early days, so obviously the budget announcement is still quite fresh. We look forward to further details about how we can engage in that, but I welcome the fact that on the face of it there's 3.4 billion of new money being invested in the NHS to try and sort out productivity as a theme. That will touch on the federated data platform and how we use data to make better decisions. It will touch on NHS app and how that can be used to give citizens a better experience, not just of their GP interactions, but also in secondary care. It will strengthen the frontline digitisation programme in NHS England, particularly looking at how electronic patient records are upgraded and moving forwards, which we welcome. And it'll bring in about 100 AI-enabled scanners, again, into that diagnostic and secondary care space. All of that, which is welcomed. The slight subtlety in the announcement is that they're expecting 35 billion of efficiency for their 3.4 billion of investment. That is quite a high ratio for the NHS if you were to look back at our historical projects. 10 to 1, don't remember many projects achieving a 10 to 1 return on their investment. That's quite ambitious. I welcome the ambition, but it means we're going to have to think about how we as an overall health system respond to that. The only other thing that I reflected on was I've been a long time advocate for automation as a technology within the NHS, and despite many of those tools being available and essentially doing what it says on the tin, we as a system have struggled to adopt that, take them on board, implement it, and then realise the benefits that come off the back of it. So my if you like, secondary reflection after I've done my optimism bit is just to reflect back on how will we as a health and care system need to put ourselves in the right frame of mind to have the right system incentives, to have all the partners within a system adopt these technologies, take out the cost associated with the productivity that we get, such that we don't just add new technologies and increase our cost base, we bring in new technologies, we operate in a different way, we put citizen at the centre, and we redefine the way in which care is delivered and liberate some of those value, some of that value. So I think my note is one of how are we ready to take on the change challenge which it will bring to us as a system.
Thank you. So I'll move on. Just something I meant to say, that Amanda is taking the lead on creating with partners the productivity framework that I mentioned. So on, if I could just talk about, if you remember our very first board, or second, I can't remember, we made a strong commitment in that board around smoking and tobacco control, and to that end we set up a centre for excellence in tobacco control. And that team are really dynamic, and they've done a really good job on our behalf, I think, over the last 18 months, I guess. But this big proposition, which is a generational change, and it links very much to what I think we'll be talking about later on around children, because obviously it's a generational change aimed at them, really, in this relation to this smoke-free proposal that's going through Parliament at the moment. So 3 points to make about that. One is that the work of the team demonstrates that if, through the research they've done in Humber and North Yorkshire, 74% of adults support the government's ambition, as indeed we do, to reduce smoking prevalence by 2030. Secondly, today, actually, right now, in London, there's an all-parliamentary event in the House of Commons, and we've got a strong team there promoting this. And thirdly, my point, you and I, Chair, have written to the Prime Minister, who's also one of our local MPs, as everybody knows, really reinforcing those points and more about really, pressing the case for making sure that legislation gets through Parliament in this current session. So it wasn't really for the debate, it was just really to flag. I mean, it's one of our fundamental priorities that we established some time ago. So just to highlight all of that and recognise the great work that's going on there.
I think Louise just wants to add something.
Today is No Smoking Day. So that is today, isn't it?
Oh, today's no, sorry, I forgot. Yes, I jumped over that. It is No Smoking Day today.
Today, yeah, 13th of March. So help is available.
How could I? Thank you very much.
It is today. You're making me doubt myself. It is today.
Thank you, Louise.
13th of March.
Yeah, we hadn't spotted that.
But it's good. Well, I had, but I just didn't read my brief book. But it's good. We've got a team there, and that's all going on today. 3 things to just quickly highlight. First of all, unsung heroes, hospital porters, but I don't know whether anybody knows this, but the hospital porters in Hull, Castle Hill, have been awarded the National Portering Team of the Year. So fantastic, and just to acknowledge that. Significant progress on our community diagnostic centres in both Grimsby and Hull. We're talking about getting onwards for 150,000 additional treatments as a result of those developments being put in place. I think it's important to acknowledge that. And then a piece of groundbreaking research, Simon, I think linked to your trust, and I'm not sure actually, Charlie, whether it links to the university. So I didn't have that data, but 3 million national piece of research on the clinical pathway and diagnosis of bowel cancer. So I think
the evaluation of the colon capsule, the hemorrhagic swallow.
That's it. Yeah. So really 3 big things there, I think, for us to acknowledge and celebrate. Thank you.
Yeah,
that's my
very
report.
impressive.
Yeah.
Lovely, Stephen. Thank you. Let's move on. We're going to go to item 11. This is the Futures Group proposal to the board. I just want to remind the board about where this work originates. Do you remember about 18 months or so ago, when we'd been going not very long at all, we began to see that there was a real tension between what we absolutely had to do today, the things that present us so urgent, and yet all our knowledge, which told us the things we really had to do were in the long term, and they were important, but they were never going to be urgent because tomorrow keeps rolling round. And it was with that realisation that Stephen and I together realised that this board had to somehow carve up its time in order that we could spend time on the urgent and we could also spend time on the important. And one of the things that we thought would be helpful in the doing of that was to create a futures group, a group who were charged only with looking at the future. We're very, very pleased when Charlie agreed that he would chair that group for us and move forward with the work. Well, roll on 15 months or however long it is. And that group has been meeting. It has been talking about, in its view, the most important things we can be doing about the long term, about the future, not the urgent things today. And is that proposal that you're bringing to board today, Charlie? So, welcome.
Thank you very much for that introduction, Sue. When we last met, I gave an overview of what was going to come up today, so we have a full version summarised in the cover paper with the longer annex. That work has been steered through a number of formal meetings of the Futures Group, but in particular through a large number of workshops, variously connecting the ICB members of the group with its additional partner members in universities and in the private sector, and latterly also quite intensively with place directors. There's a lot of detail in the paper, but to capture the essence, I'd steer you to paragraph 3.1.1 on page 6 of the cover paper, which has a rather long phrase, but I think it captures what we're about. The strategic application of data science alongside local professional wisdom and the voice of people in our communities in support of a better evidence base for integrated service delivery. That's a bit of a mouthful, so let me unpack it. 3 things. First, it's about what I think is one of the holy grails of the NHS, capturing and using data better to enhance our efficiency. Secondly, it's about local communities, about getting the benefits of data with and for and with the consent of local people and with the insight and experience of professional colleagues on the ground in health and in other public services. And thirdly, it's about the integration of the professional wisdom that we have across domains, health and education in the first phase of this initiative. And all of that is directed at the 4 ambitions of the integrated care systems that have been introduced across England, and they're all about long-term purposes around population health, around reducing health inequalities, around value for money, and around the NHS's contribution to broader social and economic development. And with that introduction, I won't rehearse the full paper, but I wanted to draw out 3 key themes. The first, I think, is crucial. This is not about inventing a new wheel. It's building on tested precedent and existing capability. That comes from a number of directions. A really big inspiration is the Born in Bradford, Connected Bradford programme, and the infrastructure that it has developed in West Yorkshire, which in large part can be piggybacked on. There are the existing data sources and approaches in Humber and North Yorkshire, which I know that IRIS, the Innovation Research and Improvement Service, is thinking about how we can better access and mobilise. There's also the academic and clinical expertise clustered around the Child of the North programme, which is jointly sponsored by the NA group of universities, but also the Northern Health Science Alliance, in other words, a group of hospitals across the north. And it's also building on a national capability in data integration in Whitehall and data analytics in the Turing Institute. And that latter point, I think, about national capacity is quite important because it reflects what the paper calls the trailblazing nature of this project. Data integration for better service delivery focused on our most disadvantaged communities, but doing this at an unprecedented geographic scale. That's what's capturing the national attention here. So it's not inventing a wheel, it's working with the grain in all ways. Secondly, the detailed mechanics of this are set out in the full paper, but the product we're aiming at is twofold. The first part is Connected Humber and North Yorkshire. It's a database that will gradually accrete data from different sources and give us the platform to provide data insights to support local professionals designing improvements in service delivery with and for communities. Secondly, it's an integrated data engine for analytics. Now, that's a phrase slightly in search of an acronym. The acronym is IDEA, Integrated Data Engine for Analytics. But essentially a network of data analysts, including the many data analysts which exist in the NHS and in other public services and in universities, and no doubt in part in the private sector, which can provide the data tools for designing and evaluating the impact of policy interventions. Now, both of those things, the database and the data engine for analytics, have direct precedence in West Yorkshire, and like there, will focus initially on children and young people, with all the potential for early interventions to bring effects across the whole life course. Now, those effects are, in potential, of quite extraordinary value. And there are some estimates and some analogies of that value on pages 9 and 10 of the cover paper. And they just signal that if we can get this right, the prize is a very, very big one for individuals, for communities, for economic productivity, and for the future cost of public services. Third theme for me, we don't underestimate the difficulty in delivering this, which is why we've had a very tight focus in our discussions, and there's a key section in the full paper on what we have come to call the knotty questions of data linkage. There are 5 of them: the legal and ethical questions on the use of data, the definition of purposes of using data, transparency of the use of the data to the citizens whose data it is, challenges of governance and oversight, and working to harness the value of that data at the smallest unit of implementation, that is, with professionals at the local level, working with families and their data at the local level. Now, those are questions of huge complexity and sensitivity, but again, in addressing them, we know we have good precedent and experience in West Yorkshire and elsewhere to draw on. There's nothing there that hasn't been done elsewhere. It's really difficult, but it's something that builds on existing expertise. So next steps, what are they to conclude with? If the board is supportive, we're looking for it to authorise up to £100,000 for 2 purposes. The first of those is to develop a fuller business case for a fuller investment in due course. In particular, in developing a more robust estimate of the kind of return on investment that we signal in the paper may well be available to us. And the second is to develop an initial delivery plan. This would be focused in the first instance on the harnessing of data across health and education. The autism diagnosis case study in the full proposal suggests one route ahead for that. But also thinking of places in the ICS in which pilot work might proceed. Now, this would be done very much with IRIS, and I think there's an assumption here that IRIS would receive this project in due course and then take it forward, because the Futures Group isn't a delivery body, it's an ideas body, but the ideas have to land somewhere, and the Innovation, Research and Improvement Service would seem to me to be an obvious place for it to land. Now, if the board is happy with that proposal of allocating up to £100,000, the next Futures Group meeting would work to spell out how that funding would be deployed to those 2 purposes, perhaps and ideally with Stephen involved. And I do think that funding is necessary. I am extraordinarily inspired by the voluntary commitment that an awful lot of people have put into this, and I'm not sure we can expect them to do too much more of that. So there's a sense now that we need to begin to anchor this in the formal, and that will require a little bit of support.
Charlie, thank you very much indeed. Are there any questions or comments? I'm going to go to Teresa first, then Max.
So, thank you. I just wanted to bring in IRIS, because I chaired the first committee of IRIS a couple of weeks ago, and the report, committee report will come to the board in due course. But one of the things that we agreed from that first IRIS committee to escalate to the board is around the lack of data management support, particularly for the born and bred in piece of work. I mean, we had lots of discussion about data and digital, and Richard was present at the committee. Does the 100,000 that is in this proposal actually cover that lack of data manager support? What was discussed at IRIS was the potential for a jointly funded data manager to support born and bred for the first 12 months, supporting particularly the acute trusts, because there was insufficient work for each of them to justify having a post on their own. But obviously there was a need for a post across the system.
Becky Bibby, who's
the lead,
that work,
Yeah.
is also a member of the Futures group. So those two things do intersect, and I think one of the challenges will be to understand where that data capability is going to come from. I think born and bred in is one of the foundations of what we can do, and it doesn't happen by itself. There has to be a lot of work with mothers-to-be to persuade them to sign up to that process, and then there has to be some work to manage the product of that process in the data points that then follow. So that's what I mean, in a sense, by a business case and that first stages of delivery plan. This will require, if we go forward with it at scale, significant additional resourcing. Talking with Jackie Andrews, the director or chair of whatever the function is of IRIS, I think there's a sense that there is quite a bit of data capability spread around,
there is,
but not necessarily harnessed to the most effective purposes. So there may be need to employ more people. There may be a sense also of reallocating existing resource, and that's what we need to think through more fully.
Thank you. Max?
Thank you. A couple of observations and a caveat, I think. So first one would be to commend this system, I think, in setting up the ICP Futures Group. I have elsewhere lots of opportunity to talk to many other ICSs, and the idea that we have dedicated time for people to think about the future, important but not necessarily burning platform in your face items, is fundamentally a move of genius, I think, and it has been my pleasure prior to joining this board to be part of the Futures Board, and I think the way in which it's being conducted, the level of challenge, the level of scrutiny is to be commended. So that was my first comment. My second is just to really welcome the recognition of just how difficult this is, and dealing head on with some of those knotty questions that you referred to, Charlie. And then my final caveat is, you know, we build on many of the successes that we've seen elsewhere in the system, in the north of England, in Born in Bradford, and in other places. Much of what we've got presented in the paper, I think, rests upon that, which is very, very sensible. But it's consent models. So if you're consenting for your child to have their data used, is potentially quite significantly different to the consent models that you might need if you were ever to move that into a wider citizen perspective. Yeah. So I am entirely supportive of this request for the funding, but I do think there's a little bit of a decision point, I think, if we were ever to move into a differently consented citizen engagement and scope for the project. And that would be something that we would want, I think, out of that £100,000, maybe that's something that we could clarify how we take that forwards.
Thank you, Max. I saw many hands here. So start with Louise, then go to Richard, then go to you, Stan.
So thanks, Charlie. I think this is a really interesting paper. I think this is a classic example of connecting the system to itself, because we've probably got lots of capability spread across all our organisations, but do we use that intelligently together, notwithstanding the very important points that Max has just made about how we do this potential data sharing. I think there's something about priming change, but then changing and not necessarily putting more in, because I think there's something about reshaping what we've got between us. We're awash with data, but are we really awash with intelligence, as in how we turn it into public health intelligence that then leads to investment priorities that then leads to the change in the population's health? So I just think we've got to think about efficiency in the longer term as a product from working better together and connecting the system to itself. But I would say that because public health intelligence should be at the heart of everything that we do. Thank you.
Richard, thank you.
I think it's terrific. It's exactly what we should be doing. Very, very supportive of it. A couple of observations that haven't been made, I think. Well, we touched a little bit on the skill set and the capabilities we need to make it fly. I think there's a great opportunity to create a data analytics profession almost across the region, get people working more closely together, learning and developing together. So that's one thing. I think the second point is around, if we get this right, tackling the health inequalities agenda, we can step to a different level in terms of our ability to really understand who's accessing services, who isn't, understand the reasons why and the patterns. So I think that's really important to bring out that in the business case for this as well. And then lastly, there is something about building on the assets and the learning from what's been done previously. I had the pleasure a few years ago of working with Lee to build the Interweave analytics platform, which is goes alongside the Interweave Exchange platform, which is the sharing data bit. There's a lot of learning came out of that, and a lot of good things were built. And in fact, the Born in Bradford one, they're using a lot of the tooling and techniques that were developed in 2021. So I think I'm just keen that we reuse the learning and the assets, because I think that will speed things up. The other asset is there was a lot of public engagement around that time, 2021. There was a big study done called Joined Up Yorkshire, which was actually a lot of interaction with the public about how they feel about their data being used in different ways, sharing for clinical purposes or for research purposes. It was really, really rich and very good stuff. Now, I think it needs to be brought up to date, but I think it'd be great if people haven't come across that to kind of understand how it was done, what came out of that, and what the public were feeling there. But overall, I think it's really exciting. You need to be really careful on the solution mix, as Max knows, because it is complicated and difficult stuff, and we need to use the right combination of tools and techniques. But overall, I think it's exactly what we should be doing.
Great, thank you. Stan.
Thank you. I mean, Futures Group have done a really good job, Charlie. I think it's a really good paper. And it's of its time. This proposal probably couldn't have been made 10 years ago, definitely not 15 years ago, because it would have all been about the box in the corner. This has got nothing to do with the box in the corner. It's got everything to do with how you store the data. But for me, the thing that will denote whether this is successful or otherwise, you did mention extensively in your report, and that is governance. Governance could stop this working completely if we get it wrong. So it needs to be dealt with in a great deal of data that needs to be absolutely clear. I can only speak from my own experience of the past, where trying to get freed up sharing of data between primary care and the acute sector, oh my God, lost count of the number of lawyers that got involved. Now, hopefully we're way beyond that, but I make the point very seriously, if we don't get the governance right, it won't succeed and we'll have wasted a lot of money.
Amanda.
Yeah, thank you. It was a really interesting paper, and I'm just conscious of some of the conversations we're having about the financial challenge we've got moving forward and some of the decisions we've got to make as a system. There's an opportunity, I think, in this to get that big picture system intelligence infrastructure vehicle that brings us all together, but also the bit around we use population health data to inform decision making, but if we're talking about prioritisation and we've got a proper decision support unit, we could actually get into some of that prioritisation. So the bit about where we allocate our funding, given it's limited, is really important. And the other bit is, I think that there's an opportunity through this to access even more money through the secure data environment and some of that national funding. Absolutely. And if we can demonstrate competency and commitment, we might just get more and more.
Yeah. Okay, so I'm going to whiz down this side of the table. I'm going to go to Anya first, and then then Nigel, then Jonathan. Anya.
Thank you, Chair. Very quickly and fully support the proposal, but just as an associated, I think, really positive point, if colleagues are aware that Baby was actually, that's Born and Bred In, was actually launched in Hull in early February, and actually within a 4-week period achieved a quarter of its target. Over 100 families signed up, so I think that's just a positive early indication of this.
Yeah, I'm completely supportive of it. I support it being linked absolutely to Iris. I'm just worried about the resources and making sure that if we're going to make this fly, it really does need to fly. So 100,000 seems quite low. So I think absolutely, as Amanda says, that we need to draw it in from elsewhere, from the wider system regionally and nationally. But also we need to reallocate our data analytics skills that we've already got on the whole discussion that we've had.
Jonathan.
Yeah, it's just a reflection again. It made me think back with the idea. The best thing to ever happened in local government was the old IDEA, the old Improvement and Development Agency, which did some fantastic work and then seemed to evaporate somewhere along the way and lost a huge amount of skill and things. So brilliant, and I love the name. But I think, in the grand scheme of things, this is peanuts for something that will do so much on the preventative agenda, the inequalities agenda, longer term. It's just the right thing to do. And Max said, he thought he was, I forget what his words were, sort of inspirational in general terms. Then let's really sell this and move it forward. Brilliant.
Thank you. Peter and then Simon.
Yeah, not wishing to prolong it too much, Chair, but we're talking about, I don't think we're finding it hard to talk ourselves into this, but the consequences of not doing it also have to be considered. I'll just make the point that there has never been a serious case review for a child death which hasn't talked about information sharing. So that's at the very hard end of not getting this right. But we will continue to perpetuate poor quality interventions for families where it's not a holistic view of the needs, and therefore we just perpetuate cycles of demand. So we really should get behind this.
Thank you. And Simon.
So yeah, hugely supportive, and the focus around children and young people as well, which is a no-brainer from my perspective. Sadly, in bed the other night, I was reading the 10 years on from Marmot report, which I think was published in 2020, and it was quite a depressing read, really, in terms of how we've gone backwards. So I am hugely supportive of this. My question is linked to sort of Nigel's, really, in terms of what the 100,000 gets us, and do we need to be thinking about how that is the seed corn for funding from elsewhere to drive this, and connected to that is the question of scale. I was there at the beginning in Bradford, actually, with John Wright, and born in Bradford. It's fabulous project, but it's been running for a number of years now and is very, very mature. We're potentially looking at something across the whole footprint of Humber and North Yorkshire. Bradford's quite a focused piece of work around an identifiable geography. Less so for us. It's just be bearing that in mind in terms of that step as we take this forwards, not to bite off too much before let's walk before we try to run. Really, I suppose is the question.
Charlie, a retort?
Absolutely. The 100,000 isn't the end of anything.
No. So being clear about what we want to use that for is.
I think it is to build a case for the kind of investment that might be needed to make this work, ultimately on a large scale, but working through a number of pilot areas. And in earlier conversation about this, I envisaged something which would have an 8-figure number attached to it. Now that may well be quite significantly reallocation of existing resource. It may be the mobilisation of third-party resource. It may be the commitment of new resource. And 8 figures is quite a wide stretch. So I've deliberately not put a full sense of the envelope around it. I think we need to be a bit clearer before we do so through this preparatory work of just what A, might be possible, what the returns on that might be, but B, how much it would cost to do this properly.
Well, I want to make just a quick point about the money, because I don't want to get hung up on the money. I mean, 100,000 is less than 0.0 something percent. I don't know what it is. I can't work it out. I don't want to bother. It's virtually nothing in the context of the 3.5 billion that we have, and we happily have spent very recently at least 3 times as much as that on setting out a whole series of proposals we discussed this morning that are not fully defined yet either. So let's not get hung up on the money. I think the bigger point about the money is, and what this is about, and we would do it quite happily, wouldn't we, in a capital programme, is we'd spec it all up and spend a bit of money on it. So it's exactly the same. So it's an investment in the future. So that would be my input on that. My more, I think, significant input is this is the fundamental business of this board. So I can pick you out 3 words. Maybe I'm going to pick out 4 actually. One's maybe 5, because the first one's 2 words together. What we're talking about here is a life-changing programme. That's what we're talking about. If we can make this work, I understand it's difficult and all that, but isn't that what we're here for? And it couldn't be more important from that point of view. And it's doing 3 things I think the ICB is and the ICS is. It's ambitious, really ambitious. It's innovative, and it's transformational. So, you know, I think we should actually be looking at this in this context. And I mean, my connected point to that is, and I think just to amplify what you said, so the Futures Group isn't about delivering this. I think basically when we get this next phase done, its work is done. And we talked a bit about, and Stan talks about the governance in a different context, really important, but as well. But we've got a delivery mechanism, and it's IRIS. IRIS at the moment is a concept, not much more than a concept. This starts to turn it into something else, I think, along with the other things. And then we're going to look at other things, aren't we? The next piece of work that the Futures Group is doing is, well, what's the next big thing that we're going to move into? So in a sense, it's also a test case of what will be coming down the line, maybe in 3 or 4 or 5 months' time, whatever it is.
Thanks, Stephen. Well, the board was asked to do 2 things as a result of your paper, Charlie. And I think you can see that this sparks the imagination of the board and the interest of the board, because it connects us back to those things that made us all really keen to be part of an integrated care board around health inequality, around the health of our population. So the first thing was to approve the vision and direction set out in the report, and I'm assuming that that's a nod all round.
Yep.
And the second was to support the next steps and approve the funding request of £100,000 to support the development and initial implementation of the test case. We're agreed. Great. Good.
You should just commission in the action the chief executive and the finance director to work that through in the minutes.
We'll work together. Thank you very much indeed.
Thank you very much.
We're running a little bit late, but this is our lunch break. I'm going to suggest we break for half an hour now, but we will be back in our seats at 2 o'clock. So thank you all very much indeed for your contributions this morning. Let's have a half an hour break. public. So welcome back to those of you who are watching us. We've got a number of important items directly following our lunch break. And the first one is we're very, very pleased to welcome our good friends and partners and colleagues to Helen Kenyon, who leads North East Lincolnshire Place, and to Rob Walsh, who is the Chief Executive of North East Lincolnshire Council. Very important partners to us, and this item is about making that partnership even stronger and even more enduring. I don't know if I need to say any more than that, or if you're happy just to pick up from there. In particular, we're asked to approve the Section 75 partnership arrangement that we are renewing effectively with North East Lincolnshire. But I think I might, unless Stephen wants to make a comment, just hand over to you. Stephen, do you want to say anything on the topic
No, I don't.
of this?
I was just going to make
Amanda.
it. Is that
Amanda.
sorry? I was just.
Yeah,
thank you. Welcome, Rob and Helen. I just want to remind the board that this is the third time we've had a conversation about the development of the Joint Committee and the Section 75 with North East Lincolnshire. So we had a presentation and a discussion on the 11th of October, and then we approved on the 8th of November that we would jointly progress the work to develop this Section 75 and move to Joint Committee. And it is an amendment to a pre-existing arrangement that's been in place for a number of years, and is a partnership across health and adult social care. And I think there's just a theme in everything that we're talking about today around partnership and integration and opportunity to do things differently with public sector spend and how we drive innovation. And I think that the Section 75 and the ambition in North East Lincolnshire is something that will continue to do that and we can learn from. The other bit, before I hand over to colleagues, is we've obviously got 6 places in the ICB. It underpins the operating model across our integrated care system of the 1 ICB, the 6 places and the 5 collaboratives. And the other 5 places are looking to learn from, not necessarily to completely adopt the model, but to learn from the innovation and the opportunity that comes out of North East Lincolnshire, and will quickly, I think, learn from that and adopt good practice and spread across the other 5. And that's all I wanted to say. Thank you.
Great, thank you. Would you like to add anything, Helen?
Double act, Chair. Helen first, me second.
Okay.
Yeah, so thank you. So just building on the earlier discussions and the comments from Amanda, it's worth noting, obviously, in the previous discussions, we were still working through some of the detail around what would be in and what would be out of the Section 75 and the partnership agreement, and we've now coalesced around about £195 million worth of funding will go into that from across the council and from the ICB. Worth noting that obviously this is a joint committee, so it's still owned by the ICB and the council. So it's not that we've completely given funding away. It's actually still our collective resources to be working together on. But hopefully what we aim to achieve from doing that, and it's identified in the paper at 3.2, are the key aims and outcomes, which is really about how do we use our funding differently to improve quality and efficiency, create an ecosystem where we've got a whole system approach to prevention and well-being. We're joining services and systems together to support service users to proactively look after themselves and be the best that they can be in terms of their health and well-being. Making sure we've got collective ownership. I think over the last 2 years we've recognised that actually what's a health issue is quite often a social care issue, and vice versa. They are inextricably linked because we're both people services. So creating that collective ownership of key issues and risks, and creating that ethos of being stronger together is what really binds the partnership, and we hope to build from going forward. So we do see this as a starting point for going forward. We've got ambitions to do more as we gain in confidence, and we will regularly review the work that's taking place. So as Amanda says, we're both learning and sharing what we're doing, but also making sure that we can provide assurance back to the board and into the council's cabinet that we are making the best use of that collective resource we've put together.
Fantastic. Rob?
Okay, Chair, briefly from me, speaking as Chief Executive of the Council. Clearly, North East Lincolnshire's history of NHS and local government collaboration is something we should all, everyone around the table actually, should be very proud of. It's something we've invested in collaboratively and in a partnership space for, since 2007, and the creation then of the Care Trust Plus. For the record, I think it's also a major step for a local authority in the current climate to continue to commit its resources into the NHS in so many ways through a joint committee model, but that's because of the relationship, the trust and the confidence we have in each other in terms of tackling some of the challenges in our patch across the socio-economic space, health and equality and so on. I'm a firm advocate in any event of collaboration when it comes to those strategic resources that govern a place, be that people, money, assets, but when you've got the lead NHS body and the lead democratically elected body working closely together, and when you get it right, it has great impact. You know, it's not saying the model's perfect, Chair, but this is the next chapter in a very long and proud history of local government and NHS collaboration, which is the way forward, in my humble opinion, in any event, and it's the right model for North East Lincolnshire. And as Amanda said, it's not about one size fitting all, but this is the next natural iteration for us. And reaching this next natural iteration, Section 75 for us is also a vehicle to foster further integration. Yeah. Again, that works for us. It's one of a number of options, but that's the one that works for North East Lincolnshire and has worked. And I think in saying my final words, hopefully, which will lead to the board supporting the implementation of these arrangements, tribute to people like Amanda, to Helen and others, across the system for supporting the development of this work, work which will complete over the next few weeks to take this journey forward. Our joint committee's been operating in shadow form for a year, and we're still not quite making it up as we go along, but we're still learning by doing. But this will give us the confidence to actually learn, do and deliver, with support from the political leadership also, which is really important from a local authority perspective. So welcome the opportunity to speak. Really exciting moment for us. Let's crack on.
Thank you. Did you want to add anything, Karina?
The only thing I would add, Chair, is that obviously from a governance perspective, we've been working with Helen, Rob and their team to make sure that Section 75 is as accurate as it can be. We've got a few I's to dot and T's to cross before completion by the end of the month. But other than that, I think we're fairly comfortable with where it's going.
Great. Okay, thank you. Stuart, and then Jonathan.
So thanks both. I'm just going to borrow Rob's words. Let's crack on. I'm not quite sure why our other places wouldn't crack on with a similar model. I get the sort of, they have to think about their own particular circumstances. But haven't we got a model that we could crack on with elsewhere? That's one of them. The other is you've said you have ambitions to do more under this kind of arrangement. I'd like to understand what kinds of things might be added to this in due season. So that's probably one question for you guys and possibly the other ones.
Yes, Amanda first.
Yeah, so if I take the first one, I think we were really clear that we've got 6 places and they're unique and different. I think we've rehearsed that before in the board environment. And what we didn't want to do was mandate a single approach because they are different. I think Rob and Helen have talked about many, many years of experience of partnership working in Section 75 in this space. And those trusted relationships and experience of working together. That's not the same in the other 5 places. I think that it's fair to say some of our places have already said they want to move quite quickly to a Section 75, but within that Section 75, potentially a pool budget, which is slightly subtle difference that we see in North East Lincolnshire, and we'll support the places to do that. I don't know that all of our places will get there, but we will share the learning, and I think the learning bit is not just the trust and how the governance works, but the opportunity to deliver and design services differently and better for the population that use them.
I assume we get a bigger bang for our buck.
Potentially we do in some areas, yeah. If we pool a budget and spend health and care money together as one, there is an opportunity to do that. Some of it relates to streamlining contracts as an example. So we'd look to learn from that.
So that's enough about the slow coaches and the laggards. What do you want to do next, above and beyond what you've already described?
Who's going first?
Okay. So I mean, I guess the logical thing, so this very much focuses on adults, though there are some all-age services within that. So one of the next phases that we'd want to move into is extending some of those, extending our arrangements into children's services, and also into much more of that public health and health promotion, health prevention type space. It's worth noting that the council's just had a new DCS and a new DPH in post as well, and obviously they need to take some time to
just go long hand on those.
Yeah, so it's a director of children's services and a director of public health in recent past, and obviously they need time to get up to speed with everything that they're taking on and get used to working with us, and we need to work together. So on all of that, because I think it is about moving at a pace where everybody feels comfortable. If you're being forced down the track, it's not helpful. I don't think it's helpful. You've got to go down that road, really wanting to go down it and understand it, and having identified some of those benefits. So I think those would be some of the areas we'd look to go at down the road, but will take us a little bit of time just to get there.
Thank you.
Just being an idealist, because I am self-confessed to add to that, we dabbled with this in the CCG days and didn't quite get there. There were some successes, but not in terms of strategic, huge, large-scale successes. I've always considered that bringing, in old-fashioned language, the big spending commissioners, old-fashioned language, forgive me, Chair, together, NHS and local government, around that wider determinants of health space, decent job, decent home, decent education. It's better to work together on addressing those challenges and achieving better outcomes than in splendid isolation. So whilst this is a vehicle for bringing health and social care together in the first instance, it should, if this works, in my humble opinion, grow, expand with confidence into a wider partnership around how we're tackling the challenges in our place together.
Thank you. Jonathan, Louise, Stephen.
Just very, very briefly, I say first, I am not speaking on behalf of my place or authority or anything with these comments, but I remember years and years and years ago, because I've been around that long, when the first joint working between, God to know what they were all called in those days, but the local authority and the health service, other politicians there threw their hands up in horror at the thought of ceding power to working with the NHS in any form or shape. And haven't we been proven wrong over the last probably 15 or more years, actually? And it is down to that trust and the relationships that have been built up. And I think any move forward for the rest of us along those lines, it can only be for the better. That's me speaking personally, not on behalf of my place.
We would be in agreement. I would be in agreement. Louise?
Yeah, thanks. I mean, the spirit of integration of working together is absolutely right, isn't it? And just in terms of examples of other Section 75s, we have one for sexual health services between our council and York and Scarborough Foundation Trust, and also with Harrogate on our 0 to 19s. And there are other examples. And in CCG days, we did also have some, but not perhaps to cover the breadth of what you're covering here. So just on that point, obviously, sovereignty and accountability to each organisation. I'm just interested when adult social care, CQC, happens, what that'll look like, and how, you know, NHS might be, are always going to be a key partner in that, but what that's going to look like for you.
Yeah, do you want me to pick
Go
that
first,
up?
Helen.
So, I think it's really important that we recognise, first of all, the whole remit of the CQC and the new inspection regime, and we've been really clear with Katie Brown, who's the Director of Adult Services, that we're working on this together. So there's a joint action plan of reviews of where we're working together, where we need to tighten up on things, because we do recognise there is a risk for the council actually within this arrangement that it's not as clear cut as in many other areas. So we need to be absolutely clear when the CQC come how the council are discharging its responsibilities and accountabilities in relation to social care. So we've got quite a detailed plan just to make sure that whoever they talk to in our system, they are clear on how all of those accountabilities are actually governed. Great, thank you. Thanks. Super.
In old-fashioned local government language, it's about line of sight, and I think that's the conversation we've had over the last few weeks, whether it's the children's space or the adult social care space. From a local authority perspective, political and exec leadership, line of sight is crucial, and this is being worked through on that basis.
Lovely, thank you. Stephen?
Yeah, so I just wanted to reflect on the exchange between Stuart and Amanda, because both positions are right, that all 6 places are different, and it's important to recognise. However, why would we be moving down a place model? And the Section 75, ultimately, I mean, it's a tool, or whatever you want to call it. It's a vehicle, perhaps a better word, for driving what I refer to as the premium out of integrating at place and doing the things that only place can do. Now, without going to the detail, one of the pieces of work that's emerging, and I think we're basically concluding on, within the wider leadership community in the ICS, is what is the purpose of a place in this context. So some things you're doing are already in that place, but there has to be a core of consistency there around what everybody does, and then some recognition of that sort of diversity in each place and its population and everything else. So I think both positions are right, and it's a bit like this. I'm now channeling Teresa, this comment she made the other day, is in some places we're still building the plane whilst flying it, and we haven't even got all the parts. In other places, we're a bit further down the line, but the programme that we've actually got in front of us in terms of the overall challenge means we're going to have to go a lot quicker, which challenges your point, Helen, and it's a well-made point, but about we can only go at the pace that, well, actually, I'm not sure it's as easy as that, given some of the challenges that we've got. So I think both points are right. But fundamentally, we do need to go very quickly.
We probably need to make some people uncomfortable.
Lisa?
One way of looking at it.
Provide an insight.
Well, the observation I'd make, Chair, is that Stephen says the Leaders Forum did quite a substantial amount of work on articulating what system maturity would look like, and has been shared with this board. And this paper is entirely consistent with that system maturity piece that we talked about. I think there is the framework that Stephen's alluded to will set, I think, a higher ambition, and I think just the very act of having those conversations is why more places are now working towards joint committees and following this example. I think more long term as well, getting to the point where we've anchored our relationship into our 6 places, recognising the democratic mandate of those 6 places is important, but it will also coincide with the move towards mayoral combined authorities and devolution, which means we can anchor the places and we know what that looks like, and then we can have a relationship with mayoral combined authorities where everybody feels secure, because it's not place or MCA. We understand there is a distinct purpose for each. So I would see this as welcome in the here and now for the system maturity, but longitudinally something which makes sense in a wider democratic.
And could I just add very quickly that adding to all of that you've got to have a coherent vehicle at place to enable delegation of resources. We can't let go of NHS resources without there being some clarity of accountability and governance. And I think that, Rob, you're alluding to the same. You can't do it the other way. So, you've got to have that in place as a minimum to move forwards.
Great. We're being asked to do 3 things in the paper, aren't we? One is note the progress that's been made since the development of the refreshed S75, since the last board update. I think we've listened with care and we're impressed with what you do. We see it as something of a template for others. Secondly, we're asked to formally approve the Section 75 partnership agreement plus the joint committee terms of reference, and agree that for the ICB Chief Executive to sign the document on behalf of the ICB Board to enable the new agreement to start on the 1st of April. Are we all happy to agree to this?
Yep.
Great. Yep. Well done. Thank you. Thank you very much indeed for coming. And I know that was brief but probably very pleasurable. We appreciate having you with us at board. Thank you.
Thank you.
Thanks.
We're going to move on now to item number 13. These are the committee reports. This is a bit of an innovation for us, as you'll recall. I think this is our 2nd month of hearing from our committees in this way. And I have to say, I like it. It works for me. I'm interested in feedback from everybody else, obviously, but I think it's helpful. So there's a narrative that goes with this, and then there's the report from each of the committees. Now, what I've got here are matters for the attention of the board. And I hope that as you were reading your papers, you just followed this legend to understand exactly what. So one alert relating to the requirement of a lead non-executive director for patient safety. This came out of the Quality Committee, and that's been brought to our attention. And we do think that the Quality Committee chair is probably the ideal person for this. Would that be right, Teresa?
No.
That wouldn't be right.
Not quite.
Right.
We can pick this up, but we have other not formal non-exec members, but retained members.
Oh, okay.
Part of the committee.
Right.
So the discussion is whether we should have one of those, and in particular.
All right. Well, I'm happy to talk about that later. That's fine with me.
Offline.
8 other matters to advise, and then system quality group, no alerts. And actually, we have to move to finance and performance to find a new alert, and that's in relation to the procurement panel governance.
Yeah. So in terms of the FPD meeting, we've changed it so that it precedes the board meeting, so we can go through the financial. And so it meant that the meeting wasn't quorate, and so we couldn't approve because the meeting wasn't quorate. So it wasn't anything wrong with it. It was just quoracy of the meeting. So now we've got those, and also we've moved it to monthly. It was bi-monthly before because we've got Richard. We'll start to chair it rather than me chairing it. So that's where we are. It was just that change in date and time. So I'll go back to the next meeting, Sue, so it gets approved.
Okay, lovely. So those are the matters for escalation to the board from the committees. What I liked about being able to really read these reports all together was it gave me an overview of all the committee work going on at the same time, and an ability to see the overlap really between the different areas and where things hook together. I found it most helpful. We don't quite know how we're going to handle this, do we? I think what I'm going to just ask, is there anything anyone particularly wants to inquire of or ask about in terms of what they've read from feedback from some of these committees? What I don't want is a report on your particular committee, unless there's something really very important to say. So anything anyone would like to raise as a result of reading these committee reports? No? Okay. And can I just ask, is there anything anyone could see that we can improve about this, or are you content with this as it stands? All right.
Can I just make potentially one suggestion?
Yeah.
In other places, what we've done is the paper that refers to, say, FPD would just like a join my finance paper rather than all being grouped together.
Right.
And then then you're talking to the same agenda item, if you see what I mean.
Right.
I mean, it's just one way of looking at it, rather than grouping them together, because then they're just sort of like linked to each other.
Are you happy for us to go away and think about that?
Yeah, that was the only thing I wanted to say, really. Thank you.
Okay. Nobody else? Thank you very much indeed. Oh, sorry.
Sorry, Chair, just for information, we've also appended last month's reports so that they're now in the public domain for public digestion, and we've also appended the action tracker following the discussion last month about how we know we get assurance back and forth from the government on any comments.
Okay, thank you. Right, we move on now to item 14. This is the performance report. This is to you, Amanda, and we're going to receive the month 10 performance report.
Yes, thank you, Chair, and I know colleagues will have had a chance to read the paper. So there's the short covering paper, then there's a summary of the kind of high-level metrics, and then there's a lot of detail in the pack. And I know some people will have looked at it all, and some people won't have had the opportunity. Just to say, I know that we've been doing some work on the narrative of this report, because although we are in March now, the data that's contained within it is almost out of date, and a lot of the things that we're talking about operationally as system leaders, chief executives and colleagues across the system in terms of the year-end performance are more up to date than that. So I will just touch on where we are now, as well as what the data in the report shows. So just, I'm going to pull out a few key things and then we can come to questions. So I just want to pick up urgent care. This is an area that I know we've talked about extensively at the board, and it's particularly how our population experience care at the front door of ED, the 4-hour target. So we've done a lot of work in the system looking at how we improve this. Urgent emergency care is a system problem, and it takes every part of our system to improve patients' experience of care in the urgent care system. So we've looked at all parts of it, and we've convened 2 urgent emergency care summits, one in Hull and one in York, looking at how we can work with partners to improve performance. We've also been working with our partners in the ambulance service, particularly around handing over at the front door. The target for the end of March is 76% in this arena. We have seen improvement despite the fact we've had challenges through winter and also industrial action. And we do hope to move towards that target as much as we can by the end of March. Just in terms of planned care, I do just want to flag that some of the areas excuse me, are still challenging in terms of the waiting list is still much bigger than we would aspire it to be. However, we are managing to reduce across the board the waiting list. And by the end of March, the waiting list will have come down, and we anticipate that there'll be a very, very small number of patients waiting 65 weeks at the end of March, which from where we were back in November is a really significant improvement. And again, quite significant improvement across the board in supporting people on the cancer pathways, both the faster diagnosis and the 62-day. In terms of primary care, we set an ambitious target in Humber and North Yorkshire in terms of additional primary care appointments, and we're on track to exceed that by in excess of 1,600 by the end of March. So again, that's quite significant progress, notwithstanding the fact that we do know that people still say they experience challenge in booking primary care appointments. And then just to reference the mental health and learning disabilities, some of those performance indicators, again, are not where we'd want them to be. We're working hard with our partners in mental health services, but we did have a data issue, and there was a discrepancy between local data and national data, and we've rectified that in terms of got underneath and understanding it, and we now know where we are.
Could I just speak of a brief comment on that? So what we're seeing on the screen, can I just be clear that data is not fully complete, and is that the position, or is that the actual position? Because it's quite important.
Yeah, no. So this is the. I think this is the national data, and what we've got underneath this is some of the local data, and there's a difference in that in terms of some of the.
But what I'm trying to get at is it material. In other words, would some of those X's that are red change to green?
So some of them have improved, and some of them.
In a way, it's all, given that we're in a public meeting. It's slightly misleading, isn't it? I'm not saying you're being misleading, but I mean the way the data's being presented, either it is, because you look at that and you would say, goodness me, this is a really serious set of concerns.
No,
or you would say, if you take what you're saying, which is just trying to get at, well, actually, that's not really representing the real position. So what we should present is the latter, if that's feasible, if that makes sense. So I was trying to understand, where is it? Where's the pinch point here? Is it actually an awful lot better, or is it just marginally?
No, it's not an awful lot better.
That's what I'm trying to get at.
Yeah. So it is slightly improved in some areas, but it's not significant.
So we still need to be concerned about the level of challenge.
Absolutely. Still, as I've said, we're
that's
not
what I was
where we want to be.
trying to get at. Thank you, Amanda. That's clear.
Michelle.
Thanks, Amanda. I know that you and the team have been working really closely with the team on this.
Yeah, we have.
Yes, there are some areas it doesn't make very much difference, which obviously we need to look at, and we've got some issues with. Some of it goes back to the trajectories that were set in relationship to the national perspective. When we didn't get the full amount of MIS, and we got a bit of the MIS, but we didn't get the SDF money. The main problem we've got is, as I've said many times, is because of the way that we database it, because of the numerous providers within the ICB. Some of our colleagues are better at providing the data than others, which is part of the problem that Amanda has. Some are free, some do that because of the data collection, some give some of their data to another ICB and others give it to ours, so we're trying to separate those out. And then sort of my organisation, which is the largest contributor to the data, has got a system that does not go into readily the national database, because Lorenzo does not talk to the national system.
So we know that, which is why we're now sending in our data on a monthly basis into so that will make a difference for some of them and make a significant difference.
I think that's helpful, but the point I'm driving at, the point of the collective board here, you were talking about some of the most vulnerable people in our local society, in our local places, represented in this data. Yes, but I was trying to get at, you know, if you looked at the acute one, I mean, we can see where we've got similar challenges, but at least I think we know that it's broadly correct. My point is either, and you've answered the question, but so I don't want to labour it too much, but, you know, so if we're looking for, you know, equality and so on between this important area of care, just as important as any of the others we're looking at, what is it we're saying? You know, we're saying that actually it's probably a lot better than it looks here, or it sounds like we're saying there's a huge amount to do still here. That's all I'm trying to get at. It's quite important, therefore, to get to the accurate position. And I wonder whether we could do something about that next time, however crude it might be. Thank you.
Okay. I think we can accept that, Stephen. Amanda, do you want to keep going?
No, I've picked out the key bits, but I think that. Thank you for raising that, and we have done some work, but we clearly need to do more and make it clearer where the difference is.
Okay.
We'll do that.
Any questions or issues for Amanda from this performance report? I wanted to ask you about the CDCs, Amanda. We talked a lot about those ages ago. Then it's all gone very, very quiet. Have we got one coming in each place? Am I right to think that?
Yes, we have, and I can just tell you where we are with that. So in terms of the CDCs, they're spread across the geography. So there's one in Scarborough, a hub in Scarborough, and that's on track. Building works continue. There's a spoke. Is
that part of the new build in Scarborough, or is it something else?
No, it's on a separate site.
It's on a separate site.
And we're building something else in Scarborough.
It's out near Morrison's.
I know.
The original plan would have been in the town centre, but it was dependent on levelling up funding, which didn't flow to what was Scarborough Borough Council at the time. But
so one in Selby. Sorry, Simon, a spoke. One in York at the Askham Bar site, that's a spoke site. There's a hub in Hull and East Riding. There's the East Riding Community Hospital spoke. There's a spoke in Ripon, a hub in Scunthorpe, and there's the Grimsby spoke. And they're all on track, and the Ripon spoke's live and the Selby spoke are live. So there's a lot of work behind that in terms of ongoing detail around that. But we got a high-level update yesterday, and in terms of the kit for these, a lot of the procurement, there's quite a big amount of work around that. It's all on track as well.
Right, okay.
So
when will we start to see the benefit of them, do you think?
Well, 2 of them are live, so they'll be receiving patients, and then when the others come on stream, I mean, it might be worth bringing a bit more of an update paper in a couple of months' time. They'll be then coming on stream. I know the team are a very small team. They've got some additional capacity coming in to support, drive the project. And then I don't have to my fingertips the amount of activity going through each of those, but we can get an understanding of that.
In total, it's about 150,000 extra seats.
I don't know what the split across the...
So that's a big number.
So we should see real benefits.
And a mix of diagnostic
once it's all
modalities in each of them. Yeah.
Nigel?
Yeah, the benefits will link to the wider clinical pathways that we're looking at that going through them. So there'll be things like breathlessness pathway.
Right.
So you'll see different benefits. So you'll see patients being cared for closer to home, with a knock on with onward referrals being potentially reduced.
Right.
So when we say what are the benefits, we've got to be careful that it's not just widget counting.
Yeah.
Because actually it's about getting and I banged on about it before, and I do apologise, but it's about getting the right patient in the right place, being diagnosed with the right modality to get the best outcome for them on their pathway.
It represents a really significant investment for us all, doesn't it, Jane?
Workforce attached to that, though, is quite a challenge still, isn't it? And that will mean across a number of our organisations, about circa 300 people in various stages of development and recruitment.
Yeah, so there's a big issue in terms of just recruiting the workforce, and the workforce not necessarily there, but there is you know, it's a part of the overall workforce plan, but that's a challenge. The other bit around diagnostics is in terms of the other aspects around moving through the waiting list and all the cancer pathways and the elective pathways. Earlier access to diagnostics will help that as well.
Yeah. Is there risk, Jane, in terms of being able to recruit everything we need for these?
There is risk within the workforce plans, yeah. Yeah, there is.
I mean, just, I don't know whether I'm preempting something you might say, but it just seems opposite as it's just come up. One of the things I think that we're going to need to have here on a regular basis is the workforce dimension, alongside the operation, the finance. And I say that because as of next Monday, we've got our national meeting.
Monday, yeah.
I mean, we're presenting our position in that context, so we certainly have to present it here. So I just make that point.
Yeah.
And that we've got to get, when we do this, we'll be doing that as well. Such a significant part of. So that's an important bit, CDC. There's an awful lot more to it.
Yeah. Stuart?
We're having trouble remembering the name there for a moment. So
Obviously not, no.
Is it moving on?
What's scene number?
On page 47, there's a workforce page. And it says, I think, just for the acutes, although it's difficult to tell, I think it's just for the acutes, possibly excluding Harrogate, who didn't provide any data. But we have 1,774 people more than we planned to have. This doesn't gel with most of the things that we hear around this table. So can I understand what that table means and why it says we got
the right page for that? I don't think my page is numbered. Oh, go on then. Yeah. Okay.
Jane may want to comment. Yes, indeed, is a short answer. So I wouldn't expect that chart to look anything like that. I think if you remember when we spoke earlier about the budget position, evidently we can't be making investments over and above the flat position, to use that language. So without looking at that, if that's growth, then the expectation nationally around workforce, or actually more specifically the costs of the workforce, not the numbers of people, is that it doesn't grow. And that was why I was saying that alongside what we're just hearing, we need an equally detailed report month on month on the workforce costs and all that goes with that, for those reasons.
Well, we do, because this implies that we've got 6% more people than we're supposed to.
Well, I'm saying that may be, but that maybe this was produced before our plans have been finalised.
Yeah, it was.
So thank you for pointing that out, because it would be misleading.
And just to add to this, we have been, we've talked a lot today already about productivity. We know productivity is going to be the watchword of the year ahead. And we've been talking about what productivity metrics can we use as part of this performance report to help us know just how productive we are. And I think, going back to the conversation we had first thing this morning, we're in a new year from the 1st of April. So from the 1st of April, we need to have some just high-level ways of understanding and knowing how productive our system is. And I know quite a lot of thinking's already gone on about
to remind you, Chair, I've asked Amanda to lead that for us in the system more generally. So I'm not saying, Amanda, that by the 1st of April we'll have it fully cooked.
No.
We will have, for the next board meeting, we'll have an output on that. So,
something that we can work with. Okay, let's move on then. Let's move on to item 15. This is around the operational plan. This is also you, Amanda. Two things: note the current status and timelines of the financial operating planning process, and request a more detailed report to be presented to the next meeting, giving further details of the draft plan submission.
Yeah, so if I just start, Jane may wish to comment, but there's a very short update paper. We still have not received the national planning guidance yet. We are expecting it this week. We were actually expecting it on Monday, and it hasn't come. And the detail around what the NHS is required to deliver will be contained within that. The timelines that we're working to are included in the report. So the high-level flash return was submitted on the 27th of February, and then the full submission, the first full submission, is due on the 21st of March, and then a full narrative across the system by the 2nd of May. So we're still working to that timescale. And there were some high-level performance metrics, predominantly focused on the acute sector, because they're easier to measure, as we all understand, in terms of what that would look like for our system. It's fair to say that there's an enormous amount of work going on across the system to triangulate the workforce, the finance, and the performance activity and what that means across the system. So that's why we want to bring back more detail when we've got it. There's a series of check and confirm meetings happening with all systems across the country. So we've already had a regional conversation. There's a further sort of regional national conversation next week with our system in terms of progress. And so hopefully by the next time we meet, we will have submitted a further plan and have a narrative that's developing. Just one other thing, and that is that the board remember that we signed off last year the joint forward plan, which is a longer term narrative. And that will come back at some point as well with a high level refresh. It won't be rewritten, but it'll be refreshed in light of the operational plan and also in relation to the transformation programme that we've got across our system too.
All right, thank you. Questions for Amanda? Stuart?
That's not really a question for Amanda so much as an observation. We appear to be in a regime that thinks it's okay to put your full plan in for next year, several months into next year, which wouldn't wash anywhere else. Nothing Amanda can do about it, I appreciate, but I thought I couldn't let that go without making that comment. So I trust somebody at the national level understands how silly this is.
I couldn't possibly comment on, but I think.
But I'm an independent.
But what I will say is that we're not waiting for that.
Yeah, good.
Obviously, we are planning on what we know from the 1st of April. But I think we should let that comment take its course.
And I also think
this is accurate.
We should learn from what we've experienced this year, sort of since Christmas with our financial planning and all our other bits of planning, that actually we have to start that a bit earlier. Irrespective of what's going on nationally, we have to do what's right for us, and I think use time as it works for us, not waiting for someone else. You know, these productivity metrics will come in July or so. Actually, I'd much rather we had a heads up before then than wait for whatever comes nationally. So I think we need to feel independent about the way we act and not encumbered by waiting for others. Let's move on to item 16. This is the finance paper, Jane. You're leading the conversation. Two things. Note the financial position for both year-to-date and the forecast outturn, and note the residual level of risk identified at M10 that will need to be managed to deliver the planned forecast position.
Okay, thanks for pointing those two things out. So in terms of the year-to-date position, we've got a year-to-date overspend of £28.1 million. So against the planned deficit, and of that 28 million overspend, 5.8 million refers to industrial action. Just to say that we've now received the funding for industrial action, and it's just slightly short of that, about 200,000 short. So we've received that money, so that will disappear in future months. We do have, as the chair's described, we've got gross risk, which actually has fallen. If you remember, in month 10 there was a financial reset, and there were further resources that came from NHS England that were distributed across the system, and our risk has started to fall, so it is decreased by £21.8 million from the previous month. And we've now got residual risk of £4.2 million that we're working with providers, and we're having those regular conversations. Month 11 information comes in today, so we've got like 2 months really to try and resolve that issue. The position on efficiencies is very much similar to the previous months. I would just want to note at the bottom of the I'm going to say page 2, it is on mine, is the 50% of our efficiencies are recurrent and 50% non-recurrent, and that creates big problems into next financial year, and that's why we seem to have a significant financial challenge. In terms of the capital position, we've got some slippage into next year, but there's a forecast overspend on IFRS 16 of £9.8 million. And we've talked about this before, but it's attributed to a lease that we think will actually fall away, and that's offset by the ISC DEL. That's the capital that's allocated to the ICB underspend of £3.1 million. And a chunk of that is because we got a very late notification of some RAC funding for Harrogate, £2 million, very, very late in the day, literally a few weeks ago, which we didn't expect to get. So that's why that overspend. Just to say that finance directors are working really hard to try and utilise all the capital spend, and these are almost daily conversations at the moment, because we hate to lose any capital, to be perfectly honest. And then the rest of the paper, I really wasn't going to go into. I don't know if people have got any questions. I'll take it as read, but those are the key highlights. And The other thing that's probably isn't in the paper that has been in the press is the funding for the deficit plans in NHS providers and ICBs. So NHS England have provided the ICB an equivalent amount of our deficit plan. Our deficit plan was £30 million, and we've now received £30 million from NHS England, and so we will declare a balanced position by the end of the year. And we've worked with the system about the distribution of that funding, so it's really, really welcome. The one thing that is worth pointing out is that we will still be treated as a system in deficit, and there are two implications. That one is access to some bonus capital. We'll be treated as though we did have a deficit, and the other is that the 30 million will still be repayable, not in 24-25, but in 25-26. So although when you see the month 11 position, things will start improving, and we should report in a balanced position. So I think that's exceedingly good news, and on a significant budget of £3.7 billion, I still think that's a good result, and everyone's worked really, really hard to achieve that result.
Richard, did you want to comment?
Yeah, just a couple of quick questions. One was on the frontline digitisation one. Been a bit of press coverage about how lots of frontline digitisation monies can't be spent this year.
Yeah.
What's the position on kind of rolling that forward into next year then? Because I'm thinking back to Max's comment about the kind of future securing of kind of technology funds.
What we're trying to do at the moment is within core capital allocations is like team and lead. So if we've got a specific allocation, because it's also true that if you don't spend those specific allocations, you cannot carry it forward. And so what providers have tried to do is make sure that they are substituting in their core capital allocation. So they'll bring forward, if you like, schemes that should have been spent last year into this year, and so they've then got this money to use, and that's what they're trying to do. There has been some slippage in the EPR schemes, I think, in Hull and NLAG, but they're trying to manage that slippage, Richard.
Okay, thank you. And the other one, again, because I'm new to this, timings then. So you're saying that month 11 closes?
Yeah, the returns are due today into us from providers.
Okay, so what's the timescale between them closing their books and you getting all your figures and being able to consolidate? I'm just trying to think about how we could ever time it for this particular meeting, that we'd have, I guess, month 11 figures rather than month. How long would you have to wait?
It takes us a few days to consolidate, so we're always after the board meeting. That's the trouble.
Right.
And we have discussed that, as Ned.
Yeah, we have.
I think we set this date because we thought we could make it.
Yeah.
If it's clear that we can't, then we should probably think as a board about how we move it on. I know that's
the
different
papers
people's
come out
diaries,
as well.
But maybe from the half year, I think.
Okay.
Because it's just irritating in March to get January's numbers.
I know it is. I appreciate it.
Particularly as things have moved on at such a pace.
Yeah.
Stuart?
I was about to make the timing point that you were just making. If we had the meeting a week later, would we be more currently all this information?
We potentially could. We probably just won't be able to send them out a week in advance. They might come out 2 days in advance or something like that, because they come to us. Then we believe that there's lots of checks and balances and consolidation. It's not an easy thing.
Karina can take the lead on just looking at what might be possible.
Yeah, okay.
I think we did have a very solid reason for doing it when we did it, but we might want to go back and revisit that. Nigel?
I see that we got industrial action costs given back. Where's that money come from? And are there unintended consequences for us going down the patch? I'm thinking about wider things like fellowships, retention, workforce, and do we know where that came from?
I don't know. I honestly don't know, Nigel. It was just something that
it's just
England.
Just one of those things you think, well, actually, in a year's time, we'll find that where that came from, and those things that we want and cherish have gone.
Miss Marple knows.
Yeah, no. I think when there's industrial action in the organisations, they track on when that action's actually happening, who they've got on industrial action and who they haven't. So I think those returns go international and they convert that into the figures.
I suppose
we had to submit financial information that said what is the impact of the industrial action based on a set of parameters.
I suppose it's more sort of centrally where they're getting the money.
I don't know.
Actually,
Nigel.
where's that
coming from? That doesn't, and what Jane said doesn't answer the central question about where is it actually coming from.
Yeah, no, sorry, I didn't know.
No, it's okay. It's okay. Maybe nobody knows.
Well, it's coming out of the public purse, isn't it?
Yes, I'm sure it is. Stephen, I think you had something you wanted to say.
Well, I just wanted to not let, and I know Jane said this, but And, you know, I know we're not quite closed and there's a timetabling issues, but I think we just need to acknowledge the amount of effort, obviously from Jane and her team, but also the wider system, to find ourselves in this position of effectively delivering our plan. Even though we've got a deficit and we are very firmly wanting to move to a no deficit culture in our system, I think it's important to just step back and acknowledge that around this board table. Thank you.
Yeah, I think that's true. Thank you. Okay, let's move on to item 17. Item 17, this is Emergency Preparedness, Resilience and Response. This is our annual update, and this is with you, Amanda, please.
Yes, thank you. So the Emergency Preparedness, Resilience and Response is a statutory function. Each ICB is required to have an accountable emergency officer, and that's me. And the ICB is one part of the system that responds in the event of a significant emergency. And as such, there's a number of core competencies that we need to display and a self-assessment that we need to do. We've done that, and we've done that as a system, and that's previously come through the board. And then there's a requirement for this annual report. So there's a short report just taking you through the risk assessment that we've done across the system through our Local Health Resilience Partnership. Any instance that we've actually responded to across Humber and North Yorkshire, and particularly the industrial action that we've had across the last, well, it's more than the last financial year, last year and a half, and then the training and exercises that we've been involved in. And I think the board are aware that actually we're not technically compliant with the self-assessment and the core competencies. This is the situation across the organisations in the ICB, but the region have said that it's sort of a technical adjustment, so they absolutely recognise we've got the competencies, but the way the reporting mechanism was put in place this year was changed slightly. We had the Regional Health Resilience Partnership on Monday afternoon, and we will engage with region as part of that, and so the system relationships are very strong, and the ability to work together is very strong as well. So it's demonstrated through, I think, the annual report. So happy to take any questions, but I think it's quite straightforward.
Let's do it.
I hate to be the harbinger of doom, but because we've got wars going on, I take mass
What, sorry?
Wars, warfare.
Right.
Have we got any special requirement to support the military in our patch? It's Catricks in our patch, for example, with a big base. And
I could answer that.
Yeah.
Good joint.
So I see mass casualties, which I guess covers people dropping bombs on us, but
So
that for a moment.
anything like that would be part of a major incident. So if we were at war and there was active warfare, the system would respond. I would suspect that would be led by the military, but probably by the police as the lead agency within the partnership, and then we would respond as part of that.
So that's broadly correct. I sit on the national NHS Armed Forces Board as the national ICB rep. So I'm just reinforcing what you're saying, but I mean those plans are already there to enact.
How with this done?
I mean the contingency plans are already there.
Okay, thank you. Let's hope we never need them.
Yeah.
Let's hope we don't. Yeah.
And I thought the hierarchy of risks was interesting. Flooding, industrial action, infectious disease, digital technology failure, public disorder, and energy supply failure. Is that based on experience, that list?
Yes,
Our experiences?
So this is based from a system conversation through the Local Health Resilience Partnership, which meets bi-monthly.
Right.
And so this comes from local experience in different organisations with partners across the system, and particularly across local authorities. So I think we tend to think about things that would happen from a health perspective, but we're part of the wider system. So particularly given the extent of our coastline, we have a significant impact from flooding. We've got significant industry that we probably don't always think about, depending on where you are in the patch, and some of the industrial sites and the hazards relating to that. And then there's always the infectious disease and the avian flu dimension, and we had, we've got experience of that.
Very interesting. Thank you.
It is interesting, but as Stuart said, we hope we don't ever need it, but we have to be prepared for it.
Yeah, we do. Any other questions for anyone around EPR?
So could I just say, I mean, I think, Amanda just referencing the LRFs, and I think the partnership working is really great, and based upon some of our experiences in the pandemic and how literally on a daily basis we were having conversations, and that still continues, but not quite in the intensity of obviously responding to. But at any point we might get notification of a river rising and that we all need to kind of be on standby, and we've got a really good system of notifying and warning and informing each other. Right. So I do have to just concur with Amanda that I think, you know, this is an NHS focused piece, but actually the partnership is right alongside each other, ready to respond, ready for anything we call it in North Yorkshire.
And that helps us with all elements of our work, doesn't it?
Absolutely.
Thank you. Okay, let's move on to item 18. This one is with you, Anya. This is around equality delivery system, our approach to the review process. I think we've seen this before, haven't we?
Yeah. We have indeed, thank you, Chair. So this is the finalisation. If you recall, we brought this to the last board in private, where we had the provisional rating of developing based on our internal assessment. Since then, we have gone through our external peer review process, our external and peer review process, which included the Humber and North Yorkshire Inclusion Assembly, the Inclusion Network, Health Watch and our Social Partnership Forum, and you should have in the appendix the summary of the feedback from those reviews. They felt that developing was an accurate reflection of our journey, so endorsed the rating that we had given. So for this board meeting, we are asking the board to confirm that scoring of developing and to approve the submission and the action plan, which is at the end of the submission. Thank you.
Thank you. Any comments, anything anyone would like to say? Like to ask? Well, I'll say, Jane, I thought it was a bit harsh when it talked about the efforts we go to look after the health and well-being of our staff. I think you do a really great job of that, and I think you go to a lot of trouble to deliver that, but it's not enough by the looks of things. So I thought that looked more than generous, actually. I'm not sure what more you could or should do.
I think when you, Chair, when you think of the process that we've been through, this follows what we're doing compared to others and how embedded it is compared to others. Right. That leads you into the developing. So I think the views were that we are providing everything that you would expect us to be providing, depending which category you're looking at. But we've got more work to do to get that to be embedded.
Right. Okay. I won't say any more. Anybody else with any observations about this document? So we approve the final rating of developing. So would we expect to be improved on developing for this time next year, Anya? Is that that's the idea?
Absolutely.
We would certainly hope so. Yes, that is definitely the ambition.
So what's the top rating? That's where we expect to be.
Developed.
Achieving, I think.
No, I think achieving's middle one, isn't it?
It's excelling, isn't it? I think.
Just bear with me 1 second. Excelling, you are right, Simon. Gold star. Achieving is the next
that's what we're aiming for.
And then the top one is excelling.
Okay. Okay, so let's keep track of this, shall we?
Absolutely, and just as a reminder from what we agreed last time, we will be bringing quarterly reports on this activity to the board. That was a request of the board last time.
Yeah, I'd appreciate that, please. Thank you. Item 19 are items for information to the board. We do religiously give you good news briefings to go with your board papers, just in case you've forgotten that actually we do some really amazing work across this geography. We've got some really amazing staff and we make a really amazing difference to people's lives in all domains. So we do include something to remind us that that's mostly what we do. There were no questions from the public. We come then to the board assurance framework, which we always have a look at the end of our meeting. So we preface the meeting with the BAF, trying to be assured that we've spotted those key risks to the achievement of our strategy. And then following our discussion, I always ask you again, is there anything we've discussed today that colours your view on our view at the beginning of the meeting? So Stephen's got a contribution and Stuart's got a contribution.
The primary care agenda that we mentioned, Roger.
Yeah, to be included. And Stuart?
I had two, one of which was primary care, bringing it sort of up the agenda so we can have a proper look at it. And on that front, we, I think, have talked at some point about having the collaboratives sort of each come and do a sort of proper session for us at a board, so you'd hear one you know, there are 5 of them, obviously, so you just hear from one at a time, one of which obviously is primary, so the same similar-ish point.
Stephen?
Can I just sort of land for the minutes of the board? Because obviously you're raising that issue at collaboratives. There is a change to our governance from April, where and we're still working that through, but essentially our sector collaboratives will all be represented here and be members of the board, therefore tightening up the operating model. So what you're talking about would be part and parcel of what we'd be doing routinely from April. So just to
and then to connect it to the BAF, you're then cite because you'd have a special primary.
Connected to everything.
And the only other one is to do with the timing of information. It's really a follow-on from the finance theme, but also a bit to do with the operational metrics that we're looking at. And if we fiddle around with the timing of this, it's a sort of BAF point, but if you're looking at information that's out of date and it needs an immediate reaction, then we're a bit slow on it, I think.
Yeah, it's particularly pointed this month because we've had so much exposure to the money, haven't we? And each week brings such a new flavour to what we're doing. So we'll think about that in the course of the month ahead. I'm going to ask you if there are any matters of any other business that anybody has raised, would like to raise. Just make sure you've got the 24th of April in your diary for our symposium event. When we've got Sir Chris Whitty coming to speak to us, and also Tina Woods. This is a session for anybody who's interested in ageing well.
Can we leave that hanging?
So, thank you all very much indeed for your attention today. Really appreciated it. The next time we meet in public will be on Wednesday, the 8th of May. But I think we've got time together in April, both at board and at a planned time out at the end of April. So thank you all very much indeed, and good afternoon. This ends our public board meeting.